suggestions for what needs to be fixed. And I will also say, if the speakers feel comfortable enough, please remove your mask when you're speaking, because it's hard to hear through the mask sometimes. And to the same point, committee members, if when you have questions, if anybody's sitting in the outside ring, if you'd come to a microphone and ask your question, we'd appreciate it. So we're going to get right started. We have the durable medical equipment, Matthew Boyd and David Hoseman.
Good morning. I want to thank everyone for the opportunity to come and speak today. My name is Matthew Boyd, and I'm the president of MAMES, the Mississippi Association of Medical Equipment Suppliers, and also co-presenting with me today is David Hoseman, who is a board member and fellow owner of a DME. So first, what is DME? I've heard a lot throughout the years. People tell me, well, DME or home medical equipment is just about delivering a piece of a medical equipment or a supply to a patient, and that's it. You just drop it off. That cannot be further from the truth. We provide equipment and supplies that are life-sustaining for patients to live their life in their home. It is not just about dropping it off. We have to collect lots of data beforehand, and sorry. Yeah, we have a problem with that. We have to collect data, documentation, which takes a long amount of time to do that. See here, sorry. Try one more time. It was just working, sorry. I just tested it. So, sorry, it is not just about delivering and dropping off a piece of equipment. We do so much more. We have to identify patients. We have to, first, when we are delivering equipment, it's not just delivering, it's assessing the patient's home, assessing the patient themselves to make sure that the equipment for them is appropriate. We have to set up all that equipment in the patient's home, and then we have to instruct them on everything, the use, the operation, how to use that equipment, how to seek assistance in case it fails, how to maintain that equipment. Those things take not just a couple of minutes, but a setup could take anywhere from 30 minutes to 2 hours for certain things. And we're not just done there. There's a lot of steps that are overlooked. We have to have, we of course offer assistance in verifying insurance, collecting all the data, and then the biggest part is collecting all the documentation. We spend hours with referral sources educating them on, hey, I need a ventilator. Well, it's not just as simple as that. We've got to educate them on how do we get that and what is required of that. And then it doesn't end there. We're available 24 hours a day, 7 days a week. During tornadoes or hurricanes, We are providing life-sustaining equipment like oxygen and ventilators, so we have to be there no matter what for our patients. It's not just a delivery personnel, it's a respiratory therapist and another person who is answering questions about deliveries and new setups. We actually are also acting as a liaison for the patient. We have to file insurance, which of course takes a long amount of time. All of those things add up to not just mean we're delivering something. And so how does DME help? Quite simply, HME and DME provides equipment to patients within their home, which is far less costly than inpatient settings. By using HME equipment, patients are less expensive in other areas of their health care. Hospital admissions, developing other comorbidities, fall prevention, skin breakdown, strokes, diabetes, and so much more are limited if HME is properly used. We also provide a wide variety of skilled and certified staff, such as RNs, respiratory therapists, and ATPs that set up all this equipment and take care of all these patients, of which we're not paid anything extra for. What COVID has shown and done for HME. I don't think COVID has shown anything new about HME. It has shown a brighter light on the HME industry. The entire goal of COVID has been to keep people in their homes and out of the hospitals and out of nursing homes, and HME is the tool that has made that happen. We have delivered countless hundreds of oxygen equipment to COVID patients within their home, which has kept patients out of inpatient facilities that have been inundated over this pandemic, and we continue to do so. So let us briefly discuss real quick how a compliant patient helps. So this is kind of the steps of a patient. So a patient has obstructive sleep apnea and needs a CPAP. And here are the steps. We have to collect all the data, which takes a long time. We set up the patient, which can take anywhere from an hour to an hour and a half. After the setup, we have numerous phone calls to ensure compliance and to make sure that patient is using it. And so what does that mean? Here is what we were first paid monthly. Medicaid actually doesn't cover the supplies while the CPAP is renting. And I would add that replacement of the supplies is a key part of compliance. But what does a compliant CPAP patient mean? It means a healthier individual who is not suffering from the many different conditions that come from untreated OSA. Heart disease, type 2 diabetes, liver problems, daytime fatigue. All of these conditions are far more expensive than paying for a piece CPAP and their supplies. I wanted a patient to be able to testify today, but in this environment, we could not, of course, risk that. So I do have a short, quick video that I wanted everyone to see of a testimonial of a Medicaid patient on HME.
I am Jean Hindley, and I'm a caregiver for my son, Ryan Hindley, who has Duchenne muscular dystrophy.
Ryan's 26 years old now. We found out when he was 5 years old he had Duchenne muscular dystrophy, which is a very aggressive disease where muscles waste away over the course of your lifetime.
So we knew things weren't right with Ryan, and we didn't know exactly what. Took him to Dr. McLaurin, and Ryan had these huge calves, and then he decided to run a blood test, and I came home and looked to see what that blood test was, and he was running a test for muscular dystrophy. Never heard of muscular dystrophy before in my life.
Pretty much they hand you a book and tell you this is what's going to happen, and they've been right every step of the way.
I start my day with having to do everything for him, because even getting him up is pretty time consuming. It takes even like an hour to even just get him out of the bed.
The most important thing for a muscular dystrophy patient is to be able to breathe.
No, I can't even go to the bathroom and leave him in it, because what if it came off? So I don't leave the room.
You got to make sure the batteries are charged up, plugged in, and you live in constant fear of running out of power.
It's very expensive to take care of a child like our son.
Obviously, I have insurance through work, but it would not cover all these medical expenses. And without Medicaid, giving Ryan the care and the expenses that we would incur would be tough.
Medicaid is very, very important to us, and we are not abusing Medicaid. And you need to understand that this is keeping our children alive.
But without Medicaid, we would be in a bind, and I can't imagine somebody that doesn't have insurance, who doesn't have a job. But here's the thing, I mean, there's some single parents that are dealing with special needs children or relatives that have these kind of issues, and they can't work. They can't. Their primary job is to take care of the patient or their loved one.
I think Medicaid has changed over the years, yes, because I'll get my bills and I'll see that I have balances, and I have to go and I have to call and say, why do I have this balance? And they say, Medicaid hasn't paid. And I go, why hasn't Medicaid paid?
I mean, this is critical for families that have a special needs child or somebody with a disease that's so aggressive, and you need that. You just got to have that support for the supplies and for the equipment, just to keep these folks functioning.
I don't have time to stay on the phone 30, 45 minutes with somebody just to for a bill when I need to be taking care of my son.
Terribly important for us to see that this continues. I think making sure there's a good line of open communication from the medical supply companies to Medicaid, and the payments keep flowing, and that there's not any hang-ups with the funding that keeps the supplies rolling for us that we need every day.
No, I used to not have to chase down bills. I would say this started maybe 8 years ago. There's no reason why I have to sit there and wonder why my son's ventilator isn't being paid for, and he needs that to stay alive.
So this is just one of the many patients that we take care of as an industry. This is a patient who requires a lot of life-sustaining equipment, as you can see, to live their life. And this is not just something that we take just simple. David and I have been in this industry for a long time and actually care for these patients and want these patients to be able to live their lives. But getting to reimbursement. So how has reimbursement in the HME industry been affected? What's caused the most problems? Well, Medicaid, of course, takes rates off of Medicare. So we're paid 20% off of the Medicare rate, and then we also have another 5% taken off for the sequestration. Unfortunately, Medicare has made a lot of bad changes over the years. In 2013, they implemented a program called competitive bidding, which had many flawed results in it that ended up costing reimbursement cuts of up to 70% in categories like home oxygen and hospital beds and ventilators. These reimbursement changes, we believe, have led to this diagram. So we have seen a decrease of 31% in locations of HME companies since 2013. There are 28 counties in our state that do not have an HME, which is an issue because you're having to travel a long way to get that equipment that you need. And the bad news is that these results actually are lower than that. We continuously see continuously see companies David and I do every day that are going out of business and that we are trying to take care of. I will now ask David to come along and make the rest of it.
I'll let you do it, Matt. I'm not. My name's David Hoseman, and I've been in the DME business since 1981. A long time, makes me rather old. I want to thank Senator Blackwell, Representative Hood, for inviting us. This is a great venue for us. So I've been doing this for a long time, as Matt said, and I'm gonna breeze through these slides.
I'm just curious, since you're a Hoseman, do you have any insights into the Lieutenant Governor? Because we would be interested to know.
Did they film us upstairs a minute ago? Don't worry about that. Thank you, Senator Wiggins. I'm gonna breeze through them, and I'm gonna hit the highlights and then move on, if y'all don't mind. So you can read, if you ask any case manager in Mississippi, any of them, if they're having difficulty since competitive bid reared its ugly head in 2016, every one of them would tell you clearly, yes, indeed. We can't seem to find vendors. We can't seem to get them out of the hospital. And so I'm going to press on every nickel and dime that we can get. And it's not all about money. Spent my Saturday and some Sunday reading over a study by Navigant. Drew, you know what this is? Okay, I figured that. Anyway, and I learned a lot. But what I was going to say, they will all tell you that it's been problematic to get these patients out of the hospital. Next slide. Okay, there they are. That's them telling. To this day, Medicare competitive bid went away in 2019, and now we can freely vend those products. We got a window in 2019. It's been wonderful. I talked to the Secretary of State about 8 years ago. His name was Delbert. And I said, we are having some conflicts. And I don't bug Delbert very much. He'll tell you that. And he said, I'm not interested in less competition. I'm interested in more. Amen, brother. I'm with you 100%. And since the competitive bid has given us we're waiting right now on bated breath for the new bid to come in, Senator Wiggins. So we're kind of scared to death, to be honest with you, because what competitive bid did is it made Drew Snyder and everybody else's life different, especially with the way we're paid. We're paid on Medicare rates, fee for service. In this Navigant study, they say, be careful of just looking at fee for service. You need to look at everything. You need to look at care. You need to look at value. Ryan's story. When I was getting ready for this meeting, and I'm not pleading here, I've been in it since 1981, I'm telling you what I know. When you listen to Ryan's story, when I was preparing for this meeting, Saturday at my Vicksburg branch, we had a warehouse manager delivering oxygen to all the people that were affected by Hurricane Delta in Port Gibson, Fayette, Vicksburg. It was more severe over there. We do this every day. We don't ask you, next slide, Matt, maybe I can get somewhere. All right, that's the indirect cost of DME that people think. I've met with a big, powerful insurance company here in Mississippi one time. And we had a conversation about, Mr. Hoseman, we can get these supplies on Amazon for this. Can you get the education? Can you get the service? Can you get the billing aspect? Can you keep a person who has COPD out of the hospital in one exacerbation of COPD? Does anybody know what that costs in the state of Mississippi, in any hospital? So be careful. Remember what they're saying. Where's the value? Where's the value of health care? Move it, Matt. Move it one more time. Okay. So that being said, I met with Senator Wiggins 2 years ago, had a wonderful meeting. And I think he would tell you that his eyes were open after that meeting about what, in fact, DME does. DME has probably serviced your grandmothers and mothers and dads and whoever, maybe your own family, through the years. That study from Navigant took 3 states, including 4 states, including Mississippi, Arkansas, Louisiana, and Alabama. We were very comparable on pricing when they did that study. Very comparable. Nothing too far away. Some of the other entities were a little bit further away, but we were comparable. When we have the 5% assessment that began in 2010, Senator Bryant's not here, but anyway, he kept asking me, David, why didn't y'all get this rescinded? Why didn't y'all get this rescinded when I met with him? Well, we're here today to try to do that. But when that happened, that was in 2010. We've been paying that price of the assessment for over 10 years, started January 1st. It's the section. I'll give it to you if you want to see it. That being said, it's time that we look at that and see the value in exactly what we're doing. That study reflected on purchased items, took the top 50 purchase items. Guess what it didn't study? And I'm going to look at Drew when I say this. It didn't really get into the rentals. We do a ton of rentals, ventilators, oxygen, hospital beds, wheelchairs, walkers. A $60 walker preventing a hip fracture has got value. Y'all get where I'm going? If you can keep the people out of the hospital by going on a Saturday morning to deliver oxygen to Port Gibson, that has value. It doesn't show up in any of this other stuff. They predominantly use purchased items. So when they took it with a 5% assessment fee, we're below. We're the last state. We don't want to be the last state. We want to be competitive. We're not asking Medicare and Medicaid don't owe DME anything. But what we do need is somebody respecting the value of what we do and paying for it reasonably, not over. I've been there. Remember, I've been in 1981. I've seen the golden commode. Those days went away 25 years ago. And so that being said, with the MCOs, we've had glitches. I'll be honest with you. And by and large, with the managed cares, they've been okay on the purchase items. It's the rental items in the Ryans of the world that we've really taken a headache. And we've talked to Medicaid about this. And I'm on a Medicaid committee. I'm not gonna speak with my mouth full. I'm on a Medicaid committee, and I was telling Delbert, and I've been on it for years, and it's a wonderful relationship we have with them. But that being said, I learned a lot from the Navigant study. I learned a lot of what we're doing. We coordinate with home health, discharge planning, hospice. It's all part of what we do. But you never hear DME when somebody's putting out, you hear about the doctors, the Nursing Home Association, the ambulance, you hear about everything else, but you don't ever hear about the DME. We're in the background making it happen in the home. There's value in keeping that person there, educated and well-trained, to stay on a CPAP, a BiPAP, a ventilator, oxygen. Okay, the study states that it saved the state of Mississippi in 2017 $291,000. So DME represents, according to that study, $23 million. When you extrapolate the 5%, it goes down to $291. I submit that you could more than save more, tons more than that, if you would just rescind that 5%. I think we can cover it and then some in savings, because according to that study, Mississippi has the most heart disease of the 4 states. And guess what? Has the most hospitalizations of the 4 states. Alabama, Arkansas, and Louisiana. Mississippi trumps. So here comes the DME. Where do we fit? If they're not going in there for unscheduled visits to the hospital or ER and using them as a crutch because they don't have services and supplies, we can save there, big time. And I would submit it's going to be more than $291,000 a year. So that being said, here are our asks. And the ask, and I am going to read these. In the sequester, in that access deal, Medicare should allow providers to dispense up to 10 days. What that means is Medicare allows us to dispense up to 10 days. We need that worked out where we can do it for Medicaid as well. So we're not delivering on Sunday. CPAP supplies should be paid with, I had a Molina, excuse me, I didn't mean to say that. I had a CAN plan that came in and said, we have a mother taking care of a child on a BiPAP that needed supplies. What that slide is about is the supplies are not paid for 10 months until they own the equipment. That could be changed. Nurse practitioners' guidelines are very confusing. Require MCO plans to follow the same guidelines in regards to coverage for Medicaid. Ensure the MCO plans cannot be more restrictive in coverage or policy than Medicaid. Differing guidelines on 4 different plans is extremely burdensome. I have gone on high dollar items, kind of like Ryan's that you saw. We've gone as much as 6 months before we got paid. That's not right. We got paid on every one of them, but we fought like hell to get it done. And that shouldn't be that way. Should not be that way. The beneficiary got their services, but we've had to fight. And Medicaid knows it. We brought it to their attention. We work well with Medicaid. But we've got to straighten up some of that business. Continue meeting with Medicaid to handle complaints and hear problems dealing with MCOs. Move these meetings to occur every 2 months. Providers cannot continue. Our job as providers is to find more ways to provide services to Medicaid beneficiaries, period. Not worry about the nickels and dimes. The 5% sequester is like as soon as you're getting ready to make a decision as a DME owner, whether you can do this or not, is a wet blanket thrown right over us. What it is, a wet blanket. Because all of a sudden, oh, I forgot about that. Continue, provide utilization data to MAMES for evaluation of AA home care to determine if under over aggregate spent to better support access. The government doesn't owe us a living, but they do owe fairness to the vendors that are out there hustling. Accept proposals by MAMES for any fee schedule changes necessary to be in compliance with legislation and to address items where reimbursement is too low to provide. We have a wonderful relationship, MAMES does, with Medicaid. A wonderful, I've been on it for 20-something years. We have done some great things through the years with Medicaid. And Drew, if I can be so presumptuous, I think Medicaid has learned a lot from the DME folks through those years that nobody ever hears about. So if it sounds like I'm touting my own horn, I'm not. Matt's not either. What we're saying is we get to live with them. We won't be in these suits this afternoon. We'll be out there doing what we do. But it makes a difference that it's fair, and it makes a difference that y'all understand where the money is spent. I get it. I know you have a budget to manage, but don't, I don't know, see the gnat before the elephant, so to speak, in expenditures. I wish I could come up with fancier quirks. I'm just not used to this. But that's what I would be looking for if I was on your committee. Thank y'all so much.
Thank you. Mr. Hoseman, would you mind making copies for the chairs of your request, as well as that study? I think you said it was the Navigant study?
So the copy of the request are on the second page of the first handout in the blue folder. It's page 2 of that. I just had a small little brief, and then and then those bullet points are at the end of that.
All right, super, thank you. I know, Mr. Hoseman, if you mind answering a couple questions. I believe in the past, depending on the rental length of the equipment, that Medicare in particularly used to, instead of renting, you purchased the equipment for items such as walkers and canes and some of those things. Is that is that still true? And if so, is it the same for Medicaid?
Yes. Most of our committee work with Medicaid has been adopting, this is why it's adopting Medicare's philosophy, not entirely, but Medicaid has a rent-to-own policy of a 10-month rent-to-own policy. That's their policy. That's different from Medicare, but it works. It's a rent-to-own. Medicare has a rent-to-own. It happens to be 13 months. That's been that way forever, and it's worked out well. That's how it works. But this Navigant study, you can read in it and tell, oh, excuse us, we didn't do the rentals. We just did the purchase, catheters, incontinence, that type stuff. Well, DME is a whole lot about rentals. And so, what's that worth to keep someone, I just want the audience to hear this. We had a frequent flyer tracheostomy patient going to the hospital and being hospitalized in Vicksburg. She was hospitalized 6 different times in a 3-month period. When she got the necessary DME supplies she needed, in this case a ventilator, she died at home a year and a half, 2 years later, never having going back to the hospital again. True story. And so that's the savings that I'm talking about, that we shore up, we prop up. And so do you really want to be looking at nickels and dimes? We do. Or do you want to talk about the value in that? And they say be careful. of what managed cares can do. Managed cares came in midterm and started taking the 5% sequester after the fact, and it hurt, to be honest with you. But the whole thing is starting up with competitive bidding and the pricing. Fee for service, competitive bidding comes down. Y'all need to hear this story. The only thing that kept us afloat in 2018, fall of 2018, or 27, I think it was 2018, maybe in 2017, is I called personally Senator Thad Cochran's office when he was alive and begged him to sign off on a bill that would promote something called the Cures Act. Y'all may have heard of that. The Cures Act was a life vest to me and Matt. It kept our business afloat for about a few months until prices stabilized. And once they stabilized, they kept us on our feet. So that Medicare passed that because they went below competitive bid. Y'all don't need to hear all this, but it's been tough in the DME business. That's why you don't see that map when any more people up there. But it was much appreciated.
Chairman Hood, you have any questions?
Thank you. Thank you for your testimony today, and I appreciate all the information you've given us. I know we have several DMEs in my district and throughout the state. You said an example of where the MCOs were more restricted than Medicaid coverage. Can you give me an example?
Yes. In a lot of our, like Ryan, the young man that y'all saw, in a lot of these claims, MCOs come into town and sign up, and they have their policies. We were told that by the Division of Medicaid, the policy should flow very similar to ours. And in fact, we were not having problems directly with the Division of Medicaid on their members. But when we would submit for some piece of equipment that was outside the norm, there are several ways to submit it. I'm not going to bore y'all with the details, but we would submit it the way we were taught to submit it. It would be interpreted from the MCO differently. And then it would say, and this is the real shame, a lot of times the big thing is you have 45 days or they can deny your claim. 45 days. We didn't have a chance to do it in 45 days. So we kept the dialogue going, fighting for everything we can do. And it went on and on. The claim eventually got paid, most of ours did, but it took forever. The regular claims, like the catheters and stuff, not as big an issue. It's when you get outside the norm with people like Ryan that need that stuff, maybe a tilt in space wheelchair to keep somebody from breaking down skin pressure. They may cost $15,000 to $20,000, so be it. But following I have in one MCO, I taught them what they should be doing from the administrative code out of the Medicaid manual, and they adopted it. That's what I'm talking about.
It's also just about how the process takes. I can submit the same paperwork to the Division of Medicaid and receive an authorization in a week. I can submit the same paperwork to an MCO, and I'm still fighting a wheelchair like Ryan's. Been fighting it for 6.5 months now in denials. So it's that process, and not only after we get approved, it's then taking 4, 5, 6 months to get paid for that claim. We can't afford to sit on a $25,000 power chair and take 6 months to get paid for that.
Thank you. Appreciate it. Randy Boyd, Representative Boyd.
Thank you, Mr. Chairman. Thank you guys for coming this morning. My question is, would it help if the MCO's codes were the same as Medicaid's as far as filing and getting reimbursement?
It would. So reimbursement is the same. They do have to follow that, but having 4 different sets to deal with, it's kind of like dealing with Greek sometimes, because you're having to go from here to here to here to here, and it's just extremely difficult and honestly makes our job 20 times harder. Yes.
So if you got that, would that relieve some of the pressure from the 5%?
I don't think quite, just because, I mean, you're taking a Medicare rate that's already been reduced and taking 20% off of that, and then another 5% off of that. So that hurts when you're already taking such a lowered rate already. When competitive bid went in, we 70% cut, and then you're taking 20% off of that, and then 5% more off of that. It does really hurt.
Thank you, but when I referred to the codes, I do mean like the process. If the process were the same as filing for Medicaid with the MCOs, and it was standardized across the board, that would help you a good bit, wouldn't it?
Yes.
Thank you.
I mentioned the 45-day period where we have to get everything in and to produce it. We've already delivered our equipment. The beneficiary has what they need. One of the things that some of them have been quick to do what they call a peer-to-peer review. A review they don't really see, and these are folks that look like Ryan. That's really not necessary because everything they needed was in the hopper the first time out. So we go back and redefend when it's not, you don't need, the doctor doesn't want to get involved. He's done his thing or her thing. And that's another thing that we've run into, peer-to-peer. And it's almost like, well, if you can't do that, maybe this will go away. The equipment's already delivered. We actually get prior approvals. Senator Blackwell knows how this works. We actually get prior approvals. It's collecting our money that is the biggest issue with the MCO.
One of you stated something about clarification for the nurse practitioner, what they do.
The CARES Act, nurse practitioners can't order DME. They can for Medicare, but for Medicaid, they cannot. It has to be signed off by the physician that's over them. The CARES Act has addressed that. We feel there might be some more legislation that has to be put within nurse practitioners' scope of practice. But in most every other state we've talked to locally, they've been able to reduce that burden somewhere nurse practitioners are able to order DME. And I have a small a piece of paper that explains that a little bit more in the packet for y'all.
Okay, thank you. Thank you, Mr. Chairman.
Thank you, gentlemen. Appreciate you coming to present.
Mr. Chairman.
Yes, sir. That's fine. Thank you.
Yes. I need to keep that blue folder right there.
Okay, thank you.
Next up, we have EMT and ambulances. We have Jamie Pafford, Vice President of Mississippi Ambulance Alliance, and Julia Clark, Secretary of the Mississippi Ambulance Alliance.
I don't know. But I think we'll do all we can.
Good morning.
Good morning, Ms. Pafford. Go ahead.
So I'm watching the clock, and I think I can catch you a few steps up during our presentation. So as he said, I'm Jamie Pafford with Pafford EMS, and I am here today on behalf of the Mississippi Ambulance Alliance and the communities our ambulance providers serve throughout the state. Thank you for the opportunity to speak before you today, and honestly, I didn't believe that when I was here back in May that I would be back up here so soon. But I do appreciate the opportunity to continue to work with you because it's actually imperative that we work together to seek the solutions to ensure that our communities across Mississippi have access to high quality EMS care across the state. And our goal this morning will actually be to share our challenges that we continue to have providing that care, and honestly to offer necessary solutions to which would ensure that our EMS systems across the state can maintain that level. Now, if you would, for just a moment, just think about the ambulance service in your community. And just think about them while I'm talking about this, because it really is about each and one of our own individual ambulance services across the state and making sure that we can keep them going. So our ground ambulance services are expected to maintain a state of readiness, just as you would imagine, 24 hours a day, 7 days a week, 365 days of the year. We just don't stop. The wheels don't stop turning. But during this pandemic, we have not backed down, we've not furloughed, and we've not closed. But yet, we have stepped up to serve the needs of every town, every city, every county within the state, and not hesitated. I cannot speak highly enough of our men and women that are on the front lines right now, that they have just put on their masks, put on their gowns, and continue to work hard for our communities, and I'm very thankful for that. But we don't do this just for the pandemic. We actually do this every day of the week. And it doesn't matter if it's this disaster, but just your normal everyday emergencies and non-emergencies that we service within our community, we're taking care of their needs. But many times you will hear us referred to as healthcare providers or the healthcare safety net in our community, and that's exactly what we are in many communities that do not have hospitals or the clinics may close at 5 in the afternoon. Then those communities start looking at those ambulance providers as their access to healthcare at that point in time. So continue to just see how vital your service is in your community. Ground ambulance service organizations, we operate on very extremely thin margins, and according to 2 GAO reports that's been in the past, we operate we're paid below the average cost given to us by Medicare. So some of the best news that I think you'll hear today is that I'm not here asking for money. I am asking you to assist in helping EMS providers find federal funds that are available at no cost to the state of Mississippi. We're not expanding Medicaid roles. We're not adding any more people. We're not billing more for the ambulance call that we're currently making. We're just simply asking to be properly reimbursed for the transports we have already made by receiving a supplemental payment from the feds. Collectively, the ambulance industry has identified a way to address this inadequate reimbursement that we currently receive for our services. You know, I get it. You guys, we're stretched thin. There isn't extra funding, and I'm sure today and yesterday as well, you heard a lot of priorities that are on your plate and that you need to try to find funds for. But we realize you're doing the best that you can with what you have, and that is why the ambulance industry would like to bring this additional resource to the table, because we believe we have the solution. We're requesting that you support us to enact legislation to allow for a SPA, a state plan amendment, to be filed on behalf of the ambulance providers in order to receive an upper payment limit, many times referred to as a UPL. So by passing this legislation next year, it will allow us to do a self-imposed assessment on ambulance services across the state, and then services can gain access to matching federal funds that can be used to ensure that our EMS systems remain the backbone of our communities. Yes, you heard me right. We are actually willing to self-assess a fee to guarantee that these funds and build the match required for this effort. We actually believe it's our only option without you finding the funds to protect and build the EMS systems across the state. You know, this is already being done in other states that are using the provider assessment to help the ambulance providers, Louisiana being one of them. They've been utilizing this process for quite a few years. Arkansas and Tennessee will actually be making payments in 2021. And then there's multiple other states that are in the process of correcting the payment structure for the ambulance services. Now, the money being infused into the system is ensuring that our EMS systems are more fairly compensated for their services. So you know, the upper payment limit is designed to close the gap between your commercial payment and your Medicaid payment. So an example of this would be, if Medicaid pays me $300 for a call and my average commercial rate is $1,000, this is the gap in between. So I'm trying to get that delta in between the $300 and the $1,000 from the feds with my matching money to try to make me more whole of what my costs are. So to do this, the Mississippi Ambulance Alliance is asking that the legislature and Medicaid agree to assist us in the process that will maximize the supplemental Medicaid payments. So by utilizing the provider assessment to create the upper payment limit program, it will be available to all providers, governmental and private. And so, you know, 80% of your state is actually, yes, ma'am.
No, I was telling him I have a question.
Okay.
He runs the show.
Okay, thank you. So, again, so it covers both governmental and private providers across the state, and it is our intent that no one is left out. And 80% of the ambulance providers in Mississippi are actually private providers. The two things that will be needed is legislation from y'all, and then a state plan amendment from Medicaid. Historically, Mississippi ambulance providers have been paid, for the most part, for our services at 70% of what the Medicare rate is, except mileage. We are not reimbursed for the first 25 miles, nor for supplies. We were very grateful for a recent adjustment to our emergency-based rate that went to 100% of the Medicare allowable during this COVID crisis. This was done in the form of a SPA with the assistance of Director Snyder, and we were very, very appreciative of that. And the funds from our Trauma Care Trust Fund was actually used to make that match. And so we received an increase in our emergency-based rate, but not the non-emergency and not our mileage. And so you know about, for a normal provider, about 60% of what they do is an emergency. About 40% is on the transfer side. So you'll kind of see those numbers throughout the state. While this was a great start for our increase that we received on our base rate, and we were very grateful of it, there is still a lot of room for further improvement. And specifically, like I said, it doesn't fix the mileage issue. And providers are not paid for their first 25 miles of a transport. And some people say, well, that's not much. But I'm a provider in Tunica County, Mississippi, and I don't have a hospital there. And so when I pick up a patient, I have at least a 40-mile transport to another service area, to a hospital in another area. So for the first 25 miles, I do not receive payment on that Medicaid patient. And so the 26th mile, it kicks in and goes forward. But for that little ambulance service that has 3 ambulances in that community that's taking care of Tunica County, that's $181 that is being left on the table. And if that community only makes around 5 or 6 ambulance calls a day, that money adds up. But what I'm telling you today is that I'm not asking you or Medicaid for the additional funds. What I'm asking you to do is to give me the ability to put the match up so that the feds take care of our issues, and this being one of our biggest issues. You know, it didn't address the non-emergency calls that are 40% of what our business is. And even with all of that being said, we are still paid below our cost of doing business. Our need to ensure that the communities are prepared for all medical emergencies is real, and it is no more evident than what we've all just witnessed the last 6 months. The workload that we've had is insurmountable. Yes, there was a lull, but we have just not stopped. But our role that our ambulance providers play in our rural communities as the healthcare safety net must be realized, and we must protect that. And what I mean by that, and I've alluded to it just a second ago, is the fact that if there's not a hospital in the community, there's the clinics that are there closed, they have your normal business hours, then the EMS system in each and every community is looked upon as the healthcare safety net in that community, and that's their next phone call if they have a medical emergency. So to ensure that we can maintain a strong statewide EMS system, and Mississippi does have a very good EMS system as well as a trauma system, and that's what we want to protect, is making sure our providers can continue at the level that everyone expects of us. We need to make sure that we can get legislation from y'all, and that we can get the support from Medicaid to move forward with a SPA program. And we can fix our own problem. I don't like having problems, and I'm a fixer, and I manage emergencies for a living, and we're close to one here, and I feel like I have a solution for you. So it's just vital that we be able to capture this opportunity this year and make sure that we don't delay this important feat for another several years until the code opens. So we look forward to working with each of you and Director Schneider and his staff in the months to come to try to put a SPA into play for the ambulance providers in the state. And so I spoke to the UPL and what we feel like our solution is today to many of our problems, but Julia is going to speak to just a couple of other points that we'd like to make on behalf of the association and our members across the state.
Morning. I'm Julia Clark. I'm with American Medical Response, and I'm also on the board of directors with Jamie and others at the Mississippi Ambulance Alliance. And this morning, I'd like to go over a couple of other things that influence our financial security for the Mississippi ambulance companies. These topics are the net brokers that we have and the 5% assessment on ambulance companies' Medicaid payments. Mississippi Code Title 4313-117B allows Medicaid to reduce the rate of reimbursement to providers for any service provided under the section 5% of the allowed amount of that service. We respectfully ask that the ambulance companies also be added to the exempt list of providers for this Mississippi Code. In 2018, Senate Bill 2836 provided for outpatient services to be exempt from the 5% reduction rate. In fact, hospital services, nursing facility services, intermediate care facility services, psychiatric residential treatment facility services, and physician services do not have this reduction in their reimbursement rates. As we continually see our reimbursements shrinking while our costs and personnel and expenses have increased, we feel compelled to ask this exemption for other healthcare providers be provided to the ambulance companies. When the net brokers were introduced several years ago, we appreciated the business reason for contracting with the net brokers, but certainly believe ambulance companies could offer insight into how this process is working and how we could provide some solutions for a win-win for Medicaid, their members, and their providers. Ambulance companies work hand in hand with net brokers on a daily basis to provide services to your Medicaid members. The net brokers work not only with us, but with our facilities that must call the net broker for a prior authorization of our services. There are some issues that we would like to put before the committee to suggest that these be worked through to make it better for your Medicaid members, providers, and a better experience for the net brokers. We have struggled to get the net brokers to pay us appropriately. Net brokers do not pay us for our first 25 miles of our ground ambulance transports and continue to pay us at 70% Medicare allowable. And we, as you've heard, the Department of Medicaid increased our emergency rates to 100% of Medicare allowable. We would like the Department of Medicaid to assist us in being able to negotiate the same rate for non-emergency and being paid for our mileage from the net brokers. There also seems to be continued confusion on what constitutes medical necessity of a patient to use an ambulance, specifically psychiatric patients, when a net broker is contacted for a prior authorization for these patients. We have provided the CMS definitions of medical necessity, and we are told that that is not within their scope of practice. So we would like to work with Medicaid to come up with a system-wide medical necessity definition that follows what the Federal Register offers and CMS offers so that there's no confusion among the net brokers. They seem to all have different definitions of medical necessity, which is confusing for us when we're calling in. One company will take a patient and then another company you call them and they won't take a patient. It just depends upon that particular company. Also, due to the tedious process that net brokers have set up, each company having a different process to get these prior authorizations, there's become a problem. Facilities have decided to bypass the net broker system when they're starting to upgrade non-emergency calls to emergency calls. What happens is a facility will call into our dispatch center and ask us to transport a patient. It'll be a non-emergency patient. We then inform them that the patient will need a prior authorization number. And we are not allowed as the ambulance company to call ourselves and get these numbers. So we will instruct the facility to go back and call any of the particular net brokers, whatever the member has. So once the facility realizes how tedious this is and how time-consuming it is, they call us back and they upgrade the trip from a non-emergency to an emergency trip. And as you can imagine, that puts a strain on our system because that puts that trip in a different priority. And we know it's not really someone that needs to go by at an emergency level. And then also what happens is now Medicaid pays for the trip and not the net broker. So the facilities have found a way to work around this, and we'd like to work with the committee here and with Director Snyder to work something out to where this is not bypassed and putting a strain on everybody's system, and that Medicaid is not losing money. So we do think there's a way to streamline that process. We also believe with the prior authorizations, we get denied. A lot of times we'll get the PA, the prior authorization, and we'll get it and be denied on the back end. We would like to have the facilities responsible or made a law responsible. In some other states, it is a law that the facilities have to get this prior authorization. If they do not, then they owe us for the trip. What happens is a lot of times for us is that they're not getting it or it's denied, and then we've already run the transport and we're not getting paid. So there are several examples of laws that make them have to pay this, or a prescriptive model that they're using in other states that are similar to pharmacy and doctors and things like that, that if the doctor orders it, then it would be paid for, that they would have no choice than to pay it. So in summation, I would like to bring to you that the companies pay us for the first 25 miles. It's kind of become a joke between us with Mr. Snyder. The 25 miles on emergency and non-emergency ground ambulance transports, that you consider the SPA this next year for a UPL program, that you increase the non-emergency rates to Medicare allowable, and remove the 5% assessment, plus explore some opportunities for us to work with the committee with these net brokers. And we'd open it up to questions now.
Thank you, ladies. And I certainly want to recognize your employees who are, out there on the front line, particularly during this COVID crisis that we have.
Thank you.
Do you use, or is there any opportunity to use telemedicine in what you do?
There is. I'll let Jamie speak to that. There is, absolutely.
Absolutely. When you think about our ambulance providers across the state, we're in every county. You have access to patients in every county through the EMS systems that are currently set up. And there are many states that are utilizing telemedicine now through their ambulance services that will allow that working relationship with the local facility, or else another platform that they're utilizing.
I'm just remembering some testimony that you both provided early on in the year when you talked about you roll out on a call, you get there, and then the patient doesn't want to be transported.
So treatment in place. It's treatment in place is what we're actually calling it, but yet we're not able to actually bill for that type of service, or some parts of it aren't quite in the regulation yet. So
right.
That's what you're referring to.
And I'm also just wondering the number of times you roll out on a call, you get there, and the person really doesn't need to be taken to the hospital. I'm just thinking telemedicine consultation with the ER. Maybe you could prevent that additional cost of going to the ER and taking up space there for a patient that doesn't really need to be in the hospital.
I think it's not only a life-saving technique because you're not cluttering up the emergency departments when a patient really doesn't need to go to the ER, and at the same time that patient, unfortunately, during the last 6 months don't want to go to the ER, and they would like a consultation there in their home. And I know many providers are currently, as far as physicians, are currently doing those consults. My mother, I sat with her the other day for her consult with her cardiologist online the other day. So we do believe that the ambulance industry can assist in that, and we would more than welcome the dialogue about how that can help Mississippians and reduce your costs, whether it's the ER bill that you no longer have to pay because that patient's being seen in a different method. So during this pandemic, our ambulance providers are waiting on the walls of ERs longer and longer and longer wait times to get their patient off the stretcher and cared for because the hospitals are overloaded. We've all been overloaded during this period of time. And so this would be one asset that we would have basically in our tool belt to utilize that system.
Thank you. Chairman Hood, do you have any questions?
I want to say one thing about the telemedicine for us. What happens is, of course, for all of the third-party players, the insurance and all, they look toward what's going to be paid for by Medicare and Medicaid. And so right now, they will take your leadership. If y'all were to start paying us for that, then we can go back to the United Healthcares and the Blue Crosses and all and say, look, Medicaid and Medicare, y'all are the leaders. They're now paying us, because I've had some insurance companies that they're very interested in doing telemedicine and not bringing people into the ED and not having those expensive ED bills, but they're not going to do anything until they see what happens with Medicare and Medicaid. So your movement on something like that for telemedicine will really make a difference for us when we go to other providers, insurance providers.
Thank you for your presentation. I think everybody in this room can think of a loved one that you've saved a life for by showing up at the house or an emergency or a wreck on the side of the road. So we want to thank you for the service that you provide to our state. I also want to thank you for your presentation today. I think you gave a really good detailed explanation, and look forward to discussing these issues as we move forward. And Representative Curry has a question.
Thank you. In a perfect world with telemedicine, that'd be great, but when that paramedic goes out to a call, whether they believe that it's not an emergency call or not, they can't make that call. They're stuck. At 2 o'clock in the morning, they've got to bring that patient in. And so I spoke with my hospital and our ambulance department. And recently, one of the managed cares, because this is about Medicaid, I know, and I don't blame you for taking your time with your wish list in front of this committee, but my hospital was hoping that you would talk about how difficult it is with managed care. They came back into our ambulance department, went a year back, and decided that $56,000 of patients that were picked up by our ambulance and brought to the emergency room were not valid and non-emergent. And they came back and took the money. Well, $56,000 on an ambulance service, which is barely surviving, is a lot of money. And so what I'd like to know, is this a common occurrence? Are you getting paid by the MCOs like you should, and help us to fix a problem that we are able to do?
The struggle is real. You're not just one incident. Part of what Julia made mention of is just having proper definitions to ensure that if a physician orders that transport, or that transport was actually an emergency situation, and we have a definition of what emergency is, then those auditors have to abide by that. You know, I love how people play armchair quarterback on Monday morning after the fact, after they weren't on the call at 3 o'clock in the morning, and oh, that wasn't a heart attack, that was heartburn. Well, guess what? I didn't give them Tums. That's not what we do. And so that's not what our job is to take care of the patient in the beginning, and then of course our billing staff continues to fight those battles with us. And I think that that's what we feel like we're able to do, is to have that dialogue, not only with y'all, but with the Department of Medicaid, and try to bridge some of those gaps, because currently the non-emergency side of this needs some work. And we would be more than willing to sit down with folks across the table and just have a good discussion about how we can make it better. Because when those claims are not paid properly, the entire system fails. Because like I said a while ago, it's about 40% of what a provider does.
And I'm really sorry, but a lot of times they're, just like the film we saw earlier with the DMEs, that child on a ventilator probably has to take an ambulance home. And, you know, unfortunately, we don't help people. Right. We want to not help people, and you're going to have non-emergency transport. It's just, it's real and it's out there, and we've got to do something about it. But we need to make sure, and I think all your other ideas are great, but, you know, I am tired of codes. The MCOs nitpick you on codes if you don't do it just right, or they change a code midstream and you've done it this way, and it's gotten real old for me.
And then I think that's one of the things that we want to continue to discuss is opening of more codes, even if they're paid at a lesser amount or at zero, as long as it's being identified that that's the type of service we provided and it is probably properly coded at that moment, then we can do other things with it on secondary levels. And then that's what we want to be able to do, is just make this process more streamlined so we're not wasting our time and our effort on the back end when all of this could be very clearly, properly done from the beginning. Thank you for your questions.
We're going to do one more question. Senator Blackman.
Thank you, Mr. Chairman. Now, as I understood you all, you're wanting the legislature to provide some assist for federal, for this 25, so you all can cover this 25 miles as non-reimbursable.
Yes, ma'am. What we need you to do is provide us legislation that instructs us to assess our providers across the state and put that in process. And we'll provide a copy of a legislation that was utilized in other states, and then we will be assessed as providers ourselves to put that money up for the federal match, so not requiring any funds from you.
Okay, so if this occurs, then will you all be able to provide better service in the rural communities? I know that in a lot of the rural counties that your contractors say we'll provide an ambulance and a half.
Right.
And then when the hospital needs an ambulance, it's in another county or it's an hour and a half away. So is this going to assist in those things?
Oh, yes, ma'am. I mean, the whole point is that we're just not properly reimbursed, and most providers across the state are fee-for-service providers. So whatever pot of money they collect, that's what they have to pay the bills and put the ambulances on the road. And so by us being able to bridge that gap from bridge the gap from what Medicaid pays to what our normal commercial payer pays, that's what we need to continue to provide this service and to better the service, better, the equipment, our assets that we have in your community, better the pay that we're able to pay our paramedics. They struggle. All of those things come into fruition when we see the funds come into those service areas, and that's what they need. I mean, that they don't have money in a lot of the counties to subsidize the ambulance service to assist with that. The tax money is not there. So this is the one way we feel like that we can put that money up, get a good match, and that it's a win-win for you for not having to come up with it, and it's a win-win for the community because they're going to be able to see their EMS system excel at that point in time.
Thank you. Thank you, Mr. Chair.
Thank you, ladies, for your presentation. Up next, we have behavioral health hospitals. We have Richard Robertson, Stuart Archer, and Ashley Wright. You're welcome to start anytime, Richard.
All right.
Go ahead.
Great. All right. Thank you, Mr. Chairman, members of the committee. Good to see everyone in person and not on Zoom or GoToMeeting or something like that. I'm Richard Robertson. I'm General Counsel, Vice President of Policy and State Advocacy with the Mississippi Hospital Association. I've had the pleasure of working with many of you for many years and appreciate the committee's interest, the Joint Committee's interest in looking at these issues on Medicaid. I think these hearings are going to be extremely productive, and on behalf of the provider community, we appreciate this very much. So everyone knows mental health and behavioral health issues are a huge challenge in the state of Mississippi. And you've got a lot of great experts who will talk about that from a hospital standpoint as well as a community mental health standpoint. And so you'll hear from the real experts on this, but I want to give you a quick overview from the Hospital Association's perspective, and just give you some data just to think through. So in the state, we've got a little, or just a little under 2,900 total licensed psych and chemical dependency unit beds in the state of Mississippi. A large number of those beds, actually a little over half of those beds, are at the state hospital at Whitfield, okay? Of those nearly 2,500 psych beds, about 2/3 of them are in state-owned facilities, and I'm not including UMC in that, but those are specialized mental health hospitals owned by and operated by the state of Mississippi. And about 1/3 of those psych beds across the state are in non-state-owned facilities. Now that includes about 33 beds that UMC has. It includes county-owned hospitals, nonprofit hospitals, and for-profit hospitals. There are 410 chemical dependency unit beds, and interestingly, the percentages are flipped. About 1/3 of those beds are with state facilities as opposed to the 2/3 that are state-owned for psych beds, and about 2/3 of the chemical dependency beds are in non-state-owned facilities. A lot of those are owned by your for-profit hospitals and some of your nonprofit hospitals and a couple of county-owned hospitals as well. The regulatory and the accreditation framework for hospitals as they work in the behavioral health and mental health space are actually in many instances more rigorous than what the hospital has to comply with just for traditional acute care beds. A lot of that is driven out of ligature concerns, concerns that someone could take something in the room or in the hallway or in the facility and use it to harm themselves, either by hanging or doing some other harm to themselves. So things as simple as an exposed hinge on a door can be a huge concern, and that can be an accreditation issue for your freestanding psych hospitals as well as your acute care hospitals. So getting in compliance with those accreditation standards and regulatory framework can be very, very expensive as you're looking at all the different things. It can go from hooks on a wall to bed rails to hinges to drop down ceilings that perhaps a ceiling tile could be moved out of the way and there's an exposed pipe in the ceiling. Things like that are issues that hospitals that are providing these services have to be extremely familiar with and extremely aware of and take all the types of precautions that are needed to keep patients safe. Your patient areas obviously have to be ligature-free. There have to be patient risk assessments, environmental risk assessments done, constant education and training with staff, because many of our hospitals, frankly, they focus more on the traditional physical health issues and not as much on the mental health, behavioral health issues. So those are constant items of education and training for many of our acute care hospitals. So those are kind of the framework there. And for our freestanding psych hospitals that specialize in mental health, behavioral health issues, some of those accreditation standards are even more rigorous, and the accreditation surveyors that come into those facilities actually have a little bit additional credentials and some tougher standards for them as well. So it's very expensive, very patient sensitive in trying to keep patients as safe as they can. For calendar year 2019, across all payers in the state, hospital data shows as the primary diagnosis code for mental health services, a little over 36,300 inpatient codes for inpatient claims for primary mental health, behavioral health diagnoses. Over half of those were either Medicare or uninsured. Okay, about 26% of them were Medicare or Medicare Advantage. About 25% of those inpatient hospital claims were uninsured. Typically, that's not just someone who's going to come in and pay out of pocket, although that does happen a little bit. Most of the time, that's just uncompensated care for the hospitals. About 20% of those inpatient stays were commercial. About 10% were various forms of Medicaid fee-for-service payments. 4% of those claims came from or were paid by United Healthcare's Medicaid Managed Care Plan. About 3% were paid for by Magnolia's Medicaid Mental Health or Medicaid MCO plan, and 1% were paid by Molina's Medicaid MCO plan. On the outpatient side, as a primary diagnosis code, about 96,600 outpatient claims were filed last year in calendar year 2019. About 30% of those were Medicare or Medicare Advantage. 15% of the outpatient claims, and this is just for hospitals, okay? This isn't all the other data that would come to you. But for hospitals, about 15% of those outpatient claims were for uninsured, typically uncompensated care. 8% were commercial. 7% were various forms of Medicaid fee-for-service. 10% of the outpatient claims for hospitals were with United's Medicaid MCO. 14% of the outpatient claims were paid for by Medicaid's Magnolia MCO, and 2% were paid for by Medicaid's Molina MCO. So, you know, one of the items that I shared with the Senate committee last February were the HEDIS measures and you know, how are we doing as far as quality goes with our Medicaid MCO programs. The 2020 data is actually kind of being on hold right now because of COVID. NCQA is not reporting out that data right now out of concerns about the impact for COVID and unfairly, you know, holding folks accountable for certain standards. But in the last full year of this, the 2018-19 data, for mental and behavioral health, United's MCO's overall score was 2.0 out of a scale of 1 to 5. So with 1 being the lowest and 5 being the highest. And there's different variations within that where they break it down into different categories. Depression, adhering to medication for 6 months, they scored a 1. The follow-up after hospitalization was pretty good. That was a 3. The follow-up after an ED visit was a 2. Follow-up after an ED visit for alcohol drug abuse was a 2. Continued follow-up after ADHD diagnosis, that's primarily your children. That was actually very good. That was a 4.0. Diabetes screening for schizophrenia and bipolar was a 1. Similarly, Magnolia, on the same scores, they scored an overall score of 2.5. For depression, adhering to medication 6 months, it was a 1. Follow-up after hospitalization was pretty good. It was a 3. But follow-up after an ED visit, it was a 2. Follow-up after an ED visit for alcohol and drug abuse was a 1. Continued follow-up after ADHD diagnosis, again, primarily for children, that was a 5, so very good on that. Diabetes screening for schizophrenia and bipolar was a 1. And, you know, the reason why those other screenings are important for your pure physical health concern is because the interplay and the connection between your mental health and your physical health. It's so important. Molina does not have the scores posted for last year. If you go to NCQA right now, there's no score there. It's listed as an interim accreditation with the next review date is February of 2021. So just real quickly, just anecdotally, hospitals, both freestanding psych and our general acute care hospitals report many of the same concerns you've probably heard from yesterday and earlier today. Concerns about getting providers credentialed, getting psychiatrists to take the Medicaid population in Mississippi or to take the commercial population in Mississippi is often very challenging. And so getting psychiatric nurse practitioners, getting licensed social workers, getting psychiatrists credentialed is challenging at times. The appeals process, when there's claims, disputes, that's very challenging. The prior authorization processes and the denials coming out of that are also extremely challenging. I'll give you one example. A hospital, a large hospital up in North Mississippi had a patient that was brought to them through the emergency department by her family. She had tried to hang herself with a pair of shoelaces from the bathroom sink. She obviously was not successful, thank goodness. When the hospital went to file that claim with one of the Medicaid MCOs, the initial denial from the preliminary review, the claim was denied, the admission was denied, and the reason for the denial was, you know, you can't hang yourself with a pair of shoelaces. I mean, that's just insulting and absurd. So those are some of the, just a snapshot of some of the challenges that that are faced in the denial and the processes. That denial eventually actually got overturned pretty quickly, to the company's credit, when it was reviewed by an upper-level manager. For the last couple of years, and coming out of the Medicaid Commission on expanding managed care, there were some recommendations about looking at pilot programs and different ways to pay for mental and behavioral health services, both in a community-based setting and also in a hospital-based setting. Not really able to update you on the status of those right now. I don't think those have gone forward, at least on the hospital setting yet. So where do we go from here from a hospital perspective? Obviously, more training, more education is needed to work with this population, because Mississippi has some significant challenges for mental health. We need more outpatient options, okay? We need more options for services in an outpatient setting to avoid unnecessary emergency department visits and to avoid unnecessary inpatient stays. We need to to coordinate better between our larger hospitals, our smaller hospitals, our community partners. We're actually in the process right now at MHA of helping stand up a statewide health information network. And one of the primary focuses of this early launch is to address mental and behavioral health challenges, to try to get the information between the hospitals, to try to reduce those unnecessary frequent flyers that come to the emergency room often, not always to the same hospital, but to different hospitals in their geographic area, and to also coordinate better with our community partners on tracking those patients and getting them the help they need. Telemedicine can be a huge benefit for mental health. So many of our areas, because of the different issues that they may have, may struggle to get the type of mental health providers that they need. Telemedicine, and particularly emergency telemedicine for psych services, can be a huge benefit. So that continues to grow as well. So I'll let you hear from the real experts on this. I just wanted to kind of give you a quick overview of where we were from a hospital perspective, and I'm glad to answer any questions.
But we'll do questions at the end, if that's all right.
Very good.
Good morning. I'm Stuart Archer. I'm the CEO of Oceans Healthcare, and I want to thank the chairman and the committee for allowing us to present today and share some information with you. A little bit about who we are. Oceans Healthcare is a pure play behavioral health provider. We've got 20 hospitals across the Southeast through Louisiana, Texas, and in Mississippi. And in those hospitals and on the outpatient side, we treated over 18,000 patients last year across our settings. Our company's been around 2 decades, and we tend to focus on underserved areas. That's really where I was raised, in a rural area, and saw firsthand the impact to not having access to behavioral health. And so it's been our company's mission to go into areas that others can't or won't, and to help change lives. And so today we're blessed to have our 20 hospitals, our 29 outpatient locations, and since 2019 have been a provider here in Mississippi and in Biloxi. At our hospital in Biloxi today, we are a full-service hospital. We treat all ages, adolescents, adults, older adults, geriatrics, and a full outpatient setting. We also, in the past year, have expanded services for the military, and for the first time, we have active duty and veterans services there in the Gulf Coast, and we're providing services now where they were having to leave and go to Texas and other areas, and so we're very, very proud of that. I would say that as a person who has the opportunity to work across multiple states, and I also serve on the National Association of Behavioral Health, I would say that across our nation, everyone is searching for solutions. Everyone is looking for, how do we do this better? And I would share with you, my personal experience over the past 2 years. We have been greeted very warmly at every door. I think the department has listened and been open to new ideas. I think the Hospital Association has been great, and so I know a lot of people are starting their conversations with their needs and their desires, and totally get that, but I want to start on a positive note by saying that certainly, everybody wants to see change. I think we can disagree on some of the actions, and I think we've had some real spirited discussions with the department on some of the ideas that we have. But, we do sense that, and I want to share that with you, and we're excited to be a part of that. And so our comments today truly are from a partnership perspective and some ideas that we've seen other communities and states try, and things that we think here might work as well. So, the first idea that we want to share, something that we're seeing, is that, certainly is the earlier comment shared, is that we really struggle with adolescent beds. I think we've all known someone or possibly had a loved one that's had a need, and adolescent behavioral health is unfortunately a growing area of our business and one of huge concern for us. Post-COVID, I think we've seen a huge spike in the request for adolescent services due to the fabric of school for many of our families being removed and the inability to kind of see what's going on with that child. And so because of that, we have a bill that we'll be introducing this year to bring adolescent beds back to Northeast Mississippi, where today there are no child and adolescent beds in that community. And the state plan shows a need for those. Those are in the state plan, but in the 92 session, there was a moratorium that was introduced on Medicaid funding for any new beds. And so we will be introducing a bill to not necessarily expand beds, but to provide a funding source for those beds. And the language today prevents any Medicaid reimbursement for new adolescent psychiatric beds, regardless of the state health plan showing that there's a need. So we'll be introducing that this year. I think the other piece that we see that we believe where we could make a bigger impact and treat more patients is the ability to provide more flexible outpatient services. Many people think of behavioral health as a hospital benefit, and for the most acute and for the most critical, that's certainly where they start. But the best behavioral health, and I think the most lasting, is going to be on the outpatient side. And I think that's where certainly we focused on the beds, and we have to have those for the most critical or for the patients that could harm themselves and others. But we're really going to sustain these changes is going to be on the outpatient side. And so we were excited this year when the state plan amendment for the first time allowed a freestanding behavioral health provider to provide outpatient services. Today, as a freestanding provider, the sickest patient I see is many times a Medicaid patient for many reasons. But at discharge, the same doctor, the same nurses, the same therapist who see that patient and many times developed a bond with them and a trust, the minute they're discharged can't see them afterwards and provide therapy to them. And so we were excited this year when the state plan amendment allowed us to provide those services, but we certainly feel like there are some big tweaks to it that need to be made. And one of those is on the outpatient side, we really have two benefits. We have something called partial hospitalization, which is just what it sounds, where we take you out of a hospital, but you're still getting a lot of intensive therapy. And then we step you down to a lesser level of care called IOP, or intensive outpatient. And so there are these stair steps. Unfortunately, the IOP benefit was removed. And as a freestanding hospital, the only benefit that I'll be able to provide is the PHP, and for a relatively short period and at half of the national rate. So I think the way that this rule is constructed has some real issues, and we're hoping to see some changes to that, so we can continue to provide care. In a recent study that we did in Louisiana with Centene, after a year of providing IOP services to Medicaid recipients, we were able to reduce readmissions by 78%. We were able to increase every single measurable health goal, and we reduced the overall cost of these patients by 6 figures in a very small sample. So it's we can make a huge difference in the lives of our community members, but as a freestanding hospital, our hands are tied in many ways, and we would like the ability to continue to treat these patients. The other two items that we had really speak to, kind of what we see as thematic issues, in that we believe as an organization, and where we see states really moving the bar is when the money follows the patient. And it really echoes my previous comment in that today a Medicaid patient, unlike other payers, is restricted from seeing any willing provider. And so today, again, if I want to provide IOP services or those services, I can't at discharge. And if we're willing to accept the rate, then we would like to continue to stress the flexibility for the patient to continue care with the providers that they've developed trust with and they've had a good outcome with. Lastly, like all providers, I think we've seen some Medicaid cuts in the past year. I would stress to everyone that the comments of the previous gentleman, that behavioral health is an extremely tough space. We are kind of, today post-COVID, seeing stressors. I think many of us would agree from kind of every angle, and I think it affects healthcare workers, it affects physicians, it affects our ability to recruit. And so when we look at our services and we look at the ability to continue to provide services in a sustainable fashion, the cuts that we've seen, certainly have had a huge impact. But more than just that, the cuts that were recently done had some structural things in them. So for instance, we're going to get hit for readmissions on a service I can't even provide. So I'm going to get hit when I can't provide some outpatient services. And so I think there's just structural things that we'd like to work with the department and all of you on to ensure that the cuts are done in a fair way and that they're appropriate to the level of care that we can provide. So I'm happy to take any questions on those. I wanted to keep my comments brief and see if you guys had any questions.
You have one more presenter? Let's hear from her, and then we'll open it up for questions.
He's with a different organization, Chairman. Or, go ahead.
We'll still let her present, and then we'll come back to questions for each of you.
Morning, everyone. My name is Ashley Wright, and I'm the Executive Director with Mississippi Behavioral Health Services. Along with me today is our CEO, Matthew Santamont, and COO, Kyle Jacob. And on behalf of all of us, I just would like to thank you for this opportunity to meet with you today to share a little bit about our organization as well as our experiences with Mississippi Medicaid and the managed care organizations. We're very thankful to be a part of this conversation, so thank you. A little bit about us. Mississippi Behavioral Health Services, we were created and formed in 2015 and received our license in 2016 to being a certified private provider with the Department of Mental Health, as well as our established contracts with the Mississippi Medicaid and MCOs. Behavioral health rehabilitation was a program created to serve qualified children and adults suffering from mental illness, emotional, and behavioral disturbances. Our policy of care is centered on the principle that rehabilitation services should be individually driven, family-oriented, and within the context of the individual's natural environment. It's our belief that those living with behavioral health issues and conditions have the capacity to learn, grow, and change, as well as achieve a life filled with meaning and purpose. Our mission is to provide individuals served with increased awareness of their own internal and external resources as necessary to be successful in their community of choice, to improve their ability to find access to resources and therefore decrease their need for out-of-home placements. As you can see on the back of our brochure, we currently have 18 fully operational sites across the state. Services that we provide are individual and family counseling, psychiatric evaluations, community support services with helping connect those local resources, peer support services, medication management, and then crisis response. But something that makes us a little bit different in being a private provider is we are able to expand on our services. For instance, in our Delta communities, there was a need, and we were sought after from the local court systems asking if we could provide a parenting class for those parents going through the Child Protective Services reunification process. And the closest class for them was here in Jackson. So if you can imagine, that was a lot of hardship on the parents with children trying to drive to and from Jackson and having multiple jobs. So we were able to meet that need for that service area, as well as implement that across the state if there were other areas in our state that needed those services as well. But due to our impactful clinical outcomes and success, we are looking to expand our coverage to begin opening more facilities throughout the state of Mississippi. Thanks to our positive partnerships that we have with Medicaid and the MCOs, we are going to be able to expand and provide more services to Mississippians in the smaller rural communities. The services, as we've mentioned, are desperately needed, and we are looking forward to expanding and filling in those gaps in these areas. Guiding our services are 4 core values that we feel align very well with the mission of Mississippi Medicaid and the MCOs, which is obviously to help our clients. Our 4 guiding values are dedication, dignity, empowerment, and quality. For MBHS, dedication means determination of purpose. It is embodied in our commitment to excellence in all that we do while remaining loyal to our organizational cause and the partnerships with our clients and you all as well today. We believe in having a welcoming environment and treating everyone with dignity and respect, but also along with dignity, we seek to empower our clients, seek to help them reach their greatest potential and to making life decisions that are best for them and their recovery. We also empower our staff to develop and implement innovative and use evidence-based practices in their work, to think outside the box and being able to assist our clients to be as successful as they possibly can. We try to provide immediate access, consistent access, and quality services to our clients that we serve. In speaking about our experience over the past couple of years with Mississippi Medicaid and the MCOs, the first thing that came to my mind was accessibility. Every MCO that we have encountered, the first thing that they do is they let us know who they are, who we can reach out to and contact, forming that connection, and let's work together for the betterment of the individuals served. Like most things in life, there are challenges and there are things that come up that cause a ripple in what you do. But because of our partnerships and connections formed with the MCOs and Medicaid, we're able to resolve those issues fairly quickly because we know who the point of contact is, who we need to reach out to, and resolve the issues as fast as possible. Also, throughout the years, we have been provided with quality feedback from Medicaid as well as the MCOs, whether that be through clinical reviews, peer reviews, site visits, any type of feedback. It's very helpful for us as an agency in driving our policy and procedures as well as our processes to help the individuals that we serve. Most recently, we just completed another site audit with the Department of Mental Health and feel that it went very, very well, and we are looking forward to their feedback in the coming weeks in providing with those services. We are also very grateful for the MCOs for being very accepting of our unique spin and how we provide our services as a private provider. They allow us the autonomy to practice in the scope of work that we do. We are boots on the ground, frontline workers in this field, and the autonomy really allows us to meet the clients where their needs are without much, if any, barriers. And in our line of work, our job is to remove the barriers for our clients and not to create them. And it is our hope that this also continues. So in short, overall, we have been very pleased with the way things have been going with behavioral health at this time. And we look forward to any questions that you may have. And thank you again for this opportunity.
Thank you, ma'am. Mr. Archer, I have a question for you, or at least a clarification. I think you, if I heard you correctly, I think you said that you're taking care of inpatients, yes, or at least in some cases, taking care of inpatients, and then cannot provide the outpatient therapy as a continuum of care. Did I hear that correctly?
That's correct.
All right. I think I'd argue that that's fairly important. Your people have, would it be the same people, the same staff, basically?
Yes, sir.
So
yes,
you've already have a relationship with the patient and their family.
It's crucial.
And
yes, sir.
basically now they've got to start over with the new therapist.
That's correct.
All right. Thank you. I know Senator Chairman Hood, sorry.
Representative Hood.
Promoted you.
Oh, no, I think that would be a promotion for you to go to the House of Representatives. Richard, I have a question for you. would you provide us a copy of all those statistics that you gave out earlier?
Yes, sir.
And also, you said something about wanting more outpatient options, but you didn't really explain what those options would be. Could you just give me a short, what would you foresee that you could use as more outpatient options?
Sure. Well, there are lots of challenges, and as I was saying, the community mental health centers and others who work in that outpatient space can tell you a lot better than I can some of their challenges. We need more outpatient options for patients to get out of the institutional setting. There's some current litigation going on about that with the Department of Justice, but so I won't go off too far into that. But you know, over the last 20 years since Olmstead, the states and the federal government have been kind of walking this, really kind of dancing this dance, transitioning patients from an inpatient setting into an outpatient setting. And while we've made significant progress in doing that in Mississippi, we've got to provide more immediate access to outpatient care for our population because we've got a growing population for mental health and behavioral health issues. So every time we've kind of, you know, moved farther along, we've got more folks in the pipeline that are needing those assistance. So things like what y'all did, I guess, a year ago with opening up the physician residency program for psychiatrists. That's a huge deal. We need to grow psychiatrists in the state and attract more psychiatrists here. That will be a huge step in improving outpatient access to care. We've got to strengthen the community mental health centers, our outpatient hospitals, our outpatient private providers. All of them, telemedicine, all those services can be a huge help. Telemedicine, I think, is a great opportunity specifically for mental health because of the types of relationships that can be built that way and because of the quick access to care in that moment where care is needed. So those are the biggest things we can do, and just trying to avoid the unnecessary inpatient hospitalizations and ED visits.
Okay. Thank you.
Senator Wiggins.
Thank you. And Richard, this is to all three of y'all, but Richard, you brought it up, so you'll be there. Thank you. In the commission report, which you mentioned about the recommendation for behavioral health and payment model. So just for background, and then I'll ask a question, is that commission studied a lot of things and came out, of all the things it studied, came out with 3 consensus recommendations. One of those is the behavioral health model that you've mentioned, correct?
For the I think that was for the complex kids.
Well, no, there was 3. I'm looking at it right here.
Yeah, and then the value-based purchasing, alternate payment
methods. In the behavioral health, a payment model for behavioral health to direct Medicaid payments to address behavioral health in the state of Mississippi.
Yes.
For the reasons that we've heard here today. And
Yes.
That was a consensus recommendation. And I think your point was that hasn't yet been done.
That's my understanding, right?
Okay, and that recommendation was directed the Division of Medicaid to work with the MCOs as well as our providers to provide a pilot program and study a pilot program for behavioral health. And my sense, and I appreciate y'all's work on the commission, was behavioral health. If we want to, what I called bend the curve, we get into behavioral health and we can head off some of these problems that we're seeing. And I'm speaking as Judiciary B chairman when in the criminal justice system that we're seeing. I mean, that's what we talked about, right?
That's right, and that's a huge challenge.
And there's no resources, and the reason we wanted behavioral health is because you can provide these resources, Medicaid can pay for that, and we can head off these things so we're not spending down the road as much money as we are and having the corrections problems that we are, because these kids and these people need this help. It's a what do y'all call it? It's a collaborative model, right?
Right.
Right. Am
Yeah.
I correct in saying that?
It absolutely can be.
Okay.
And, you know, and it's a challenge for the Medicaid population. And the statistics I was just sharing with you too, we've got a significant amount of uninsured population coming into the hospital setting, inpatient setting, outpatient setting, but significantly on the inpatient side, that has to be addressed too because it leads exactly to those problems. So we've got to get more coverage for that population because that is a huge population, those low-income working adults, not meaning to get up on this tangent necessarily, but that is a huge opportunity to provide extended coverage to keep folks out of the situation that you just described.
Thank you. Mr. Chairman, I would just say that these providers, along with others, participated in this commission and came out with a lot of good recommendations, including one of these. And I think it's incumbent and would be good policy for these committees sitting in House to, look at those things and incorporate or certainly seriously take into consideration the recommendations that were made, because what we're hearing today is what was heard back then, and these recommendations were made for a reason to try to address those things. So thank you very much.
And if I could add one quick thing, one of the things, though, that we do have to be careful about in value-based purchasing with Medicaid is Medicaid is already the lowest payer. So it's hard for providers to take a lot more downside risk on that payment because they're typically the lowest payer of the group. So you've got to really find that sweet spot, which is why that language in the statute that was put in a few years ago is so important, where it says you can do alternate payment methodologies. You just can't force it on the provider because it has to work. Otherwise, these guys are going to be out of business and everyone else. So you've got to find that sweet spot.
I'm sorry, Richard, but that was the point of this recommendation, and I'm not going to sit here and read it, but it's in that publication, that for everybody to work together in a collaborative model, including the private pay, the MCOs, the Division of Medicaid, to address the behavioral services for particularly these children before before they become adults.
Yep.
Okay, thank you very much.
Yep.
Thank you, and thank you, Senator Wiggins, and I also want to recognize your work in that commission as well.
I'm not asking for that. I'm just, I think
I'm just
things
tossing it
tend
to
to get lost up here, and the work was done by these folks.
Right, and you brought up a good point yesterday that I want the group here to follow up on. When we passed the bill, Tech Bill in 18, talking about the credentialing components being accepted by the MCOs and Medicaid, we need to, it was certainly the intention, I believe, of the legislature to make that happen. We just need to follow up on where that fell apart. We're going to do one more question. Representative Hines.
Thank you. Thank you, Mr. Chairman. Rich, are you familiar with remote patient monitoring?
Yeah, just enough to be dangerous, yes, sir.
Do you think that would be effective in the services provided by mental health?
I think it can be. I think, I may be getting too far ahead of my skis on this, but a little that I know about remote patient monitoring is it's often used for more complex patients. So it depends on the patient, but certainly mental health can be one of those use cases for it. But really, more broadly, not necessarily broadly, probably more specifically, just the use of telepsychiatry and telemedicine in the psychiatric space with all the other remote patient monitoring needs. But remote patient monitoring can bring in, data for diabetes, data for oxygen levels, heart rates, and all those different things too that may have a significant impact for that patient whose primary diagnosis is a mental health or behavioral health issue. But there's just a lot that we can do through remote patient monitoring, through just simple telemedicine procedures as well. So, but yeah.
All right, well, thank you.
Thank you.
Thank you, folks, for coming and presenting. Up next, we have the community mental health centers.
Good morning. Chairman Blackwell and Chairman Hood and fellow committee members, thank you for this opportunity. The community mental health centers appreciate being part of the conversation. Before I begin my formal presentation, I would like to say a few remarks. We understand that there will always be varying viewpoints as to how the process of change should unfold. We believe that no one group or entity has all the answers. We certainly don't claim to. While we don't have all the answers, we do have our experiences and lessons learned from those experiences, and we would like to candidly share those with you here today. With that said, I hope the information I present this morning is taken in the context in which it is intended, to give the information and data to make informed decisions. I will begin with what is going right. First, I believe all of us have the same end goal. All the stakeholders from departmental health, the community mental health centers, the Division of Medicaid, you all in the legislature and advocacy groups are united with our goals, our common goals for the public mental health system. We want to reduce our reliance on institutional care, improve outcomes, contain costs, and resolve our issues with the Department of Justice. So clearly the problem lies not with where we are going. I think we're all pointed and headed in the right direction. I think the rub lies with the path we have chosen to get there. The community-based portion of the mental health system has long struggled with funding. Historically, the CMHCs were built on a very shaky financial foundation. The state institution received the lion's share of state funding, roughly a 70-30 split in favor of institutional care. But thankfully today, those inequities are being righted. You, the legislature, are doing your part. You've increased funding for community-based mental health services over the past few years by $16 million and added an additional $4 million this past legislative session. Ms. Bicula and her administration at DMH are also doing their part to right the wrongs of decades of inequitable funding. She recently carved out $8 million from her existing budget and shifted those funds to community-based care. The Division of Medicaid is doing their part by working in tandem with the Department of Health to add new services to the menu. And we, the CMHCs, are doing our part by using those funds to deliver those services in the community. The Titanic is slowly but surely being turned around, but an iceberg does await. While each of us are doing our part, managed care is negating that forward progress, and maybe more importantly, it is crippling the state's effort to meet the demands of the Department of Justice. We certainly understand the drive behind the Mississippi CAN program. We understand that Mississippi Medicaid cannot have a runaway budget. We get it. The Mississippi CAN program has given the state much budget predictability. But unfortunately, that is not a complete picture. There has been much collateral damage. Budget predictability for the state has come at the expense of budget predictability for providers. Provider costs have increased as we struggle to deal with the added bureaucracy of tracking service authorizations, fighting service denials, and chasing claims. Budget predictability for the state has come at the expense of mentally ill individuals who are being denied access to care at unprecedented numbers. Budget predictability for the state is coming at the expense of the state standing with the Department of Justice. As a matter of fact, on the heels of the DOJ filing suit against the state, managed care imposed a 5% assessment on all CMHC reimbursements. This assessment essentially negated much of the $8 million that Ms. Mikula had just shifted to support additional community services. One step forward, two steps back. Last summer in the DOJ matter, Judge Reeves ruled that the state needs to increase access to community-based care. We agree, and our data dovetails with that assertion. If you will please turn to the first page in your handout, you'll see a document titled Serious Mental Illness, Prevalence Rates versus Utilization Rates. If you'll turn your attention to the bar graph on the left side, you will see that nationally, it is estimated that 5% of the population has a serious mental illness, such as schizophrenia. When you apply that 5% to Mississippi's adult population, you're looking at around 114,000 individuals, which is represented by that first bar. Of the estimated 114,000, the community mental health centers are serving approximately 60,930, which is slightly more than half of the estimated need. Of the 60-some-odd thousand that we are serving, only 6% of the approximately 3,899 individuals receive psychosocial rehabilitation services, or PSR, a tiny sliver of our patient population. Despite such paltry utilization numbers, this service is being aggressively managed in the managed care arena. Managed care company A had an adverse determination rate of 54% statewide. Managed care B, 14%, compared to a modest denial rate by fee-for-service or regular Medicaid at 1%. Why is this important? PSR is a day program which participants are taught the skills necessary to be successful in the community. In other words, it is a key service to meeting the DOJ demands of reducing reliance on institutional care. We know that those who do not attend PSR are 2.5 times as likely to be hospitalized. When hospitalized, their length of stay is twice as long, and they are 14 more times likely to be civilly committed to the state hospitals. Some examples. We have a 58-year-old diagnosed with schizophrenia. He has a history of yearly commitments to Mississippi State Hospital and multiple outpatient commitment orders. Paranoid delusions, refuses to take his medication, is often very verbally aggressive when interacting with others in the community. Denied PSR and remanded to a lower level of care. Have another individual who also suffers from schizophrenia, repeated hospitalizations not only in Mississippi but in the state of Illinois, has command hallucinations, meaning he hears voices telling him to harm other people or himself, has a history of suicide attempts. He too denied and remanded to a lower level of care. These two patients are examples of those patients at the center of the DOJ litigation. They are two examples of patients that cycle in and out of the state institutions. We want to give them the services they need to stay in the community, but managed care is not allowing us. These same aggressive utilization management practices are being applied to PACT. This is one of the premier services as DOJ sees it, with regard to keeping patients from cycling in and out of the state institution. One managed care company has an average adverse determination rate of 34.25% among the CMHCs that I was able to collect the data. The primary reason it's being denied? Well, since participating in PACT, the individual has not been hospitalized. Well, guess what? PACT is working. The team is doing exactly what DOJ wants us to do, keeping these individuals out of the hospital. And now managed care is distorting that success and using it as a means to deny care. Again, one step forward, two steps back. Now we turn to children's services. If you'll please turn to the second page of your handout and look at the graph on the left-hand side. You will see that nationally it's estimated that 20% of all children and youth have a serious mental health issue. If you apply that percentage to Mississippi's children and youth population, it is estimated that 141,000 plus children in our state have a serious emotional disturbance. It's represented by the first bar. Of the estimated 20%, the community mental health centers are serving 33,788, or 1/4 of the estimated need. Of the mere 1/4 that we are serving, only 16% of those children are receiving one of our more intensive community-based services, day treatment. Day treatment, just like PSR, plays a key role in reducing hospitalizations and institutional care for children. Once again, despite the low utilization numbers, managed care is aggressively denying access to care. Managed care A denied 29%, managed care B 3%, and fee-for-service Medicaid 0. Most of these children that are being denied are very fragile children. We had a 14-year-old from an abusive home. She witnessed a younger sibling sustain serious burns at the hands of her mother. Her mother was subsequently charged and sent to prison. CPS removed this child and her 2 siblings from the home. Her father didn't want her, so she bounced around in multiple foster care homes. Separated from her other siblings, she has intrusive memories, attachment issues, anger outbursts, and frequent crying spells. She's been involved with youth court. She was denied day treatment, and I quote, "Your child is not improving. Your child has been in treatment for over 1 year and has made limited progress. It is not clear how additional treatment will benefit your child." I have an 11-year-old from a single-parent impoverished home, recently suspended from school for telling another student, and I quote, "I want to rape you like in the jailhouse." Verbally and physically aggressive with his mom and with peers, recently bloodied the nose of another student. This child, too, was denied, and I quote, "Your child does not have a risk of being placed outside the home or in residential care. This level of care is designed to help children stay out of inpatient care. Your child's symptoms can be treated with a lower level of care." It's appalling. Unequivocally, we are not running PSR or day treatment meals, nor a PAC meal. Unequivocally, these individuals need intensive services. Unequivocally, access to care is being wrongly denied, and unequivocally, the state standing with DOJ is being jeopardized. There is criticism to be made, and that is that we're not doing enough. I will take that criticism. We want to do more, but we aren't holding the keys to the access to that care. Neither is Department of Health, neither is the state. Right now, managed care is holding the keys. Since 2018 and before the pandemic hit, as a primary result of these aggressive utilization management techniques, the CMHCs have seen the closure of 19 day treatment programs and 6 PSR programs. The end result, the elimination of hundreds of community-based care slots. This is not what DOJ is looking for. The employment of aggressive utilization techniques by managed care is not unique to Mississippi. Unfortunately, these tactics are commonplace around the country. I've included in your packet an article regarding a 2019 court ruling from a federal class action lawsuit regarding this very issue. It's the WITS lawsuit, which was filed on behalf of tens of thousands of mental health patients that were denied access to care, much in the same manner that I have just described to you. In short, the federal judge ruled the insurance company was much more worried about their bottom line than patient care. Simply put, the company was denying access to care for the sake of profits. In that ruling, the judge enunciated 8 guiding principles that must be used when the insurance company makes determinations regarding access to care. Those 8 principles are listed in this article and are considered the gold standards of care. This past legislative session, a bill, Senate Bill 2621, was introduced that would have forced all the managed care companies to adhere to those 8 guiding principles. Similar legislation has passed in other states. Unfortunately, Senate Bill 2621 did not pass, but we hope to reintroduce this coming session. It's important to note that after the WITS ruling, the CMHCs did see a substantial drop in the number of denials from the MCO involved in the WITS litigation. Originally, they had one of the higher denial rates among the MCOs, and now they're much more in line with fee-for-service and Medicaid. I've also included in your packet an interesting article put out by the American Psychiatric Association regarding readmission rates for suicidal youth pre- and post-managed care in Missouri. Essentially, the study determined that kids admitted to Missouri hospitals for suicidal ideation were twice as likely to be rehospitalized after the state transferred most of its children into managed care. The reason? Managed care companies are approving shorter lengths of stay. What is going on in Missouri is very similar to what is going on in Mississippi with our crisis stabilization units. The crisis stabilization units are 16-bed acute inpatient care facilities designed to divert patients from state institutions. Since being turned over to the communal health centers, the CSUs have been pretty darn successful. Statewide, approximately 92% of the patients that go to a CSU are diverted from a state institution. If you'll please flip to your 3rd page of your handout, you'll see a graph titled Crisis Stabilization Units. At the CSUs, the average length of stay is 13.52 days across all admissions. Regular fee-for-service Medicaid pays for an average of 13.16, very close to the entire stay. Compare that to the 3 managed care companies, 6.93, 8.86, and 8.03 days. In other words, on average, 4 to 5 days of stay per patient are not being paid for by the managed care companies. Once managed care quits paying for the bed, state grant dollars are used to subsidize that care. So in many instances, the state is paying twice for that bed. First, via capitated rates to the managed care company who does not complete the care, and again through state grant dollars used to subsidize that care. And of course, if the individual goes on to state hospital because the managed care companies quit paying, the state is picking up that care at 100%. So I think we have to ask ourselves, is managed care really saving the state money? Is managed care increasing access to care? Is managed care improving outcomes? Is managed care helping us with the Department of Justice lawsuit? We think we can give the state the same budget predictability and cost containment success by increasing access to care and improving outcomes, not simply by denying care. I believe that Division of Medicaid ultimately wants this as well. I have listened to Mr. Snyder and repeat his vision of rewarding providers on value, not volume. We agree. He's right. We need to be more innovative. We need to show that what we are doing works. We applaud his vision and we stand behind him. Unfortunately, that vision is not being realized in the current managed care environment. I've included in your packet a proposal that was put together at Mr. Snyder's request, and it addresses his vision of rewarding value. It was done on a short time, so admittedly it's a less than perfect proposal, but at least it serves as a starting point. And we very much appreciate Mr. Snyder giving us that opportunity. I've learned from Division of Medicaid and others that the biggest economic drivers of Medicaid's budget are chronic health conditions such as obesity, diabetes, and hypertension, and all the terrible stuff related to smoking. Within the Medicaid population, more than half of individuals with disabling psychiatric illness also have claims for diabetes, cardiovascular disease, and pulmonary disease. Those daunting statistics are begging for an integrated care approach. PSR participants are a captive audience. We have them 5 hours a day, 5 days a week. So rather than denying access to care for PSR, allow us the flexibility to address their mental and physical health care needs during that time. The basic infrastructure is already in place. We can incorporate smoking cessation programs, diabetic screenings, physical exercise to combat obesity. The list goes on. There is much low-hanging fruit to be harvested. Yet our time is spent fighting for the right for that individual to walk through the door, rather than figuring out how to maximize the service. We want to be part of the solution, we truly do, but not just any solution, the right one. And we respectfully request that the community mental health centers be carved out of managed care, at least until the state has resolved its issues with the Department of Justice. Thank you.
Good morning. I have a few remarks I'd like to make, and Phaedra covered a lot of what, and then for the sake of time on your part, I'm not going to. I have COPD, so I'm going to try to speak as loud as I can, so I'll get close to the microphone. The points I want to make echo what Phaedra has said. At this point, I guess, in the presentation, is where we come to you with our ask. And Phaedra's already asked one. We listened to the hearings yesterday, several other of the provider groups. We'd like to be carved out of managed care. We'd like to have the 5% assessment from our payments removed. We'd like for the managed care companies to continue to reimburse us at the same rate as Medicaid rates, and there's discussion going on that it's going to allow them to negotiate rates below what Medicaid pays. Now, whether that passes or not, we don't know yet. And the final thing is to fix the state fair hearing system, which each managed care company organization has a process. So if you get denied services, you can appeal. You have a certain number of days. The final ruling in that, you can ask for a state fair hearing. There is no defined process or time period on when that hearing is supposed to take place. We have member community mental health centers in our association who have people that have been waiting for 2 and 2.5 years to get a hearing. These are folks with serious mental illness or serious emotional disturbance in children, and they deserve an answer. I mean, they're Mississippians. They need to be listened to and heard with their issues. And I wanted to point out for the record, and I don't know if anybody's pointed this out today or yesterday, United Health Group's second quarter profits this year jumped to $6.6 billion, double the earnings for the same period last year and far beyond expectations. Centene, on July 15th of this year, reported a profit of $1.2 billion, more than double its profit from the second quarter of 2019. Molina projects between $674 million and $707 million in profits this year. Half of the community mental health centers in the state are operating in the red. Part of that right now is due to COVID. But still, there must be a more Mississippi-friendly system of reimbursement for the care for our most vulnerable citizens. I know the members of this joint committee and the members of Medicaid and the Department of Mental Health are compassionate people. We are asking on behalf of the people we serve to let your compassion for their well-being be your guiding light, not the profits of $1 billion managed care company. If we are to get better, the care of the individuals we serve must come before the profits of the managed care companies. Thank you. And I guess we'll open up for questions.
Thank you both. Chairman Hood? Any questions from the committee?
Representative Curry.
Thank you. And Phaedra, I guess my questions will be to you. So, of course, I talk to my Region 8 director often, and right now, well, let me go back just a moment. There were 3 community mental healths that were in the black before COVID, so I'm not sure where they are now. They're probably all not doing well. And and I'm not sure that the word that I should use is a czar, but we put in a bill that we were going to have a czar to come out, or whatever you want to call it, and look at, why some community mental healths were doing okay and why some weren't. And it wasn't to bash anybody. It's to see what can we do. We're being sued by the Justice Department for community services. What do we need to do to help? Because it's so vitally important. And so I think the czar may be here now, almost November. Last I heard, I don't know if one has been done or not, and the report is due by December. But I hope that this czar looks at how much our managed care companies owe you. Today, managed care companies owes my Region 8 $850,000. They fight and they scratch and they, do everything that they can to go through these appeals. And you can imagine if you were owed almost $1 million, how much care you could give to somebody else. And most of the care that I talk to my director, they do for free. Most of the people that come to community mental health have nothing. So when you do actually have somebody that has Medicaid and don't get paid, it's a tremendous burden. So I want my mental health Region 8 paid, and I want them paid soon. We're getting sued. And if the managed care companies are not going to be a partner with us to get through this crisis that we need to get through, then we need to move on to get better partners. So can you tell me, and this may be a question you can't answer, but can you tell me how much is owed to our community mental health throughout the state?
I don't have statewide data. There's some directors here that can speak to that directly. At my center, on any given day, I'm probably at $150,000.
I'm sorry, how much?
$150,000 on any given day. And it is, there's a lot of blood, sweat, and tears trying to get claims paid correctly. Once you're paid, then there are recoupment demands, and so you don't necessarily get to keep what you put in your pocket.
Right. Thank you.
Senator Blunt, did you have a question?
Yes, thank you, Mr. Chairman. Quickly, could you give us a status update on where the lawsuit stands?
Gosh, I don't think I'm the best person to give an update. I know Departmental Health is here and will be presenting shortly, and they are probably better positioned to speak to that than I.
Good, thank you. I'll ask them. Secondly, what determines, I'm looking at the disparate treatment that a patient, or that you can be paid for a given patient based on what managed care organization that patient is part of. What determines where that patient ends up, whether they're with managed care organization A or B or C, or with their fee-for-service with Medicaid, and how is that allocated?
I think that would be a better question for the Division of Medicaid. I'm not sure what goes on behind the scenes and how they're assigned to different managed care companies. I know that they do have an open enrollment period annually in which they can request to switch to another managed care provider, but I cannot speak to what goes on behind the scenes in that regard.
Okay, I just see obviously it has a big impact on you, whether that patient walks in the door with one card or a different card, depending on what they've got, but.
Right,
okay.
we don't have any control over which managed care company they're assigned to.
Okay, thank you.
In the interest of time, I've got two more representatives that want to ask a question, but I would ask that you keep it brief. Representative Boyd.
Thank you, Mr. Chairman. I will. Two parts, but you talked about carving y'all out of the MCOs, and do you think that would increase cost to the state if you did that?
No, sir. I think the state grant dollars we better utilize toward those who are truly indigent rather than subsidizing those that have a payer source.
Okay, and what about your lawsuit against the MCOs? How does it stand?
The 5% assessment, yes, that is working its way through the courts. We have prevailed initially here in Hinds County, and then they are appealing to the Mississippi Supreme Court.
Thank you.
Representative Hines.
Thank you, Mr. Chairman. I have one simple question. If you paid your bills and your business or home the same way managed care companies are paying you, would your lights be on?
No, sir.
Okay.
Thank you, Ms. Cole, Mr. Dugan. And Ms. Cole, could you provide the committee with your comments, if you have that? And
You all should have a copy of
yeah, but you went into great detail about, we have your packet, but I didn't know if you had any other prepared remarks or if you were just reading from the folder that you gave us.
Yes, I'd be happy to do that, but most of that is included in this. It speaks to the different services and the denial rates and consequences of
All right.
that.
Thank you
yes,
both.
sir, I'll be happy to do that.
Appreciate it. Next up, we have Pediatric Behavioral Health, Dr. David Elkin and Dr. John Damon.
Mr. Chairman and committee members, good morning. Thank you for the opportunity to speak here today about what Mississippi's future for children in behavioral health could look like. My friend and colleague John Damon is going to add some flesh to the bones here, so I'll just start us off with some general ideas. By way of introduction, I'm a child psychologist by training. I work at UMC, and I'm the director of the Center for Advancement of Youth. The acronym is CAY, we just call it K, and that's a fully integrated center. Behavioral health. I had a professor in grad school who said behavioral is anything a dead person doesn't do. So in terms of behavioral health, we cover it all, and we try not to use terms like psychiatry and psychology because they tend to be pejorative. We bring in together in one center psychiatrists, psychologists, social workers, nurse practitioners. We have speech, OT, and PT. We have a fully integrated center. And we were able to pull that off and put that together because of the support of Medicaid about 6 years ago. We were partnered with Medicaid, and it's working well. It's working well, but I want to discuss some improvements to what is already working. Let me start off with an illustration, I suppose. Let's say you have an 11-year-old child from Carthage who is acting up in the classroom. That child may or may not have ADHD, but the child is probably going to go to his or her pediatrician there in Carthage. And that pediatrician may or may not recommend medication or behavior therapy. Not many resources in the area, of course. That child's going to use resources and cause problems in schools. The key today, I think, is talking about access to quality care. And those 4 words, I think, should be an umbrella over what we're all discussing here today in everything, access to quality care. We are advocating for greater access, but access to quality care. We want to advocate that the dollars be leveraged in a more efficient manner because this partnership can work and can work in a good way. Medicaid pulled data on kids that were seen in our center a few years ago. I wish I could say that we did these data, then y'all could accuse me of lying, but these are Medicaid's own data. Kids that move through our center compared to kids that receive treatment as usual across the state. They're matched on age, race, region of the state, diagnosis, and ethnicity. And kids that move through our center utilized 1/2 of the resources of kids that did not receive treatment as usual. By that I mean, you oftentimes hear about people saying, if we spend money on kids now, we're going to save money in the future. That may be true, but we're talking about ways you can save money right now. And as you've heard before, earlier this morning, a lot of those savings are going to the back pockets of national companies. They're going out of Mississippi. We have strong opinions on that too, but I'll let that be. This Medicaid Mississippi model is working well and honestly has sort of become the envy of a lot of places around the world and around the United States as well. We want Medicaid to use its dollars wisely. We want Medicaid to be a collaborative, data-driven partner with us in what we do, a wise purchaser of programs. In a sense, Medicaid is like the central bank, if you will. So we have a few ideas to sort of increase the collaboration between Medicaid and what we're already doing, something that Medicaid would value. We've heard about value-based care, and my colleague and friend, Dr. Damon, is going to talk more about that as well. But first and foremost, we need to increase reimbursement for applied behavioral analysis for children with autism spectrum disorder. This is a dire crisis facing a lot of kids in our state. Again, John can talk about that, but it has to happen because most pediatricians don't know what to do with a child with autism. They can be disruptive in a classroom, they can cause problems at home and cause a lot of distress. But ABA works, it's been shown to work over and over again, it's efficient, and these kids can get better. When you have a certain color of hair, it pretty much stays the same until you get in your 50s and it turns gray. But with autism, you can actually improve the outcome and trajectory of these kids, and that's why ABA is so important. So first of all, ABA therapy for kids. You've heard before the importance of telehealth, and we would advocate strongly for the continuance of reimbursement for telehealth in schools. The goal here is to keep care local. That kid in Carthage wouldn't have to travel to Jackson or anywhere else. Care could be delivered in school. Mom doesn't have to take off work and travel. The child can move in and out of a classroom setting, and care can be delivered right there. This increases the outpatient options that Mr. Robertson spoke about earlier. It would basically make an outpatient setting out of a school system. That's happening in community mental health agencies around the state and around the world, but it can happen here too. We are working with Ole Miss to start training their teachers on how to handle behavior problems in the classroom. We're also partnering starting next week with Alcorn State and some of the schools in Port Gibson to handle some of the behavior problems in the school remotely with telehealth. During this public health emergency, telehealth in schools is being reimbursed. Our concern is that when the public health emergency ends, that it will no longer be reimbursed, and we would like to advocate strongly that everything be opened up in terms of school-based clinics. As a side note, I was seeing a child and his mom about 3 weeks into the coronavirus pandemic. I heard some clacking around, some noise and stuff in the background, and I said, "Are y'all in a cafeteria or something like that?" And the mom leaned into the camera and said, "No, we're in the Waffle House." And I thought, why not? She said, "They've got Wi-Fi services, we can get a bite to eat, and it's close to my house." They were in South Mississippi. That is an expansion of the treatment options on outpatient that you keep hearing about. So ABA therapy, telehealth in schools, The third thing we'd like to push for is reimbursement for the ECHO program. ECHO is a program that was started in New Mexico. It's being used in other states around as well. It's being used in Missouri quite effectively, where providers out in the state, physicians, counselors, therapists, whomever, can be educated on how to handle medication management, behavior problems. They can consult with people in one place, particularly UMC and other places. We want to expand the base of knowledgeable providers across the state so that people don't have to come to Jackson. They can take care of kids where they are, be they in Liberty, Mississippi or in Nesbitt, Mississippi. It doesn't matter. If they're where they are, they know how to handle kids in a primary care setting, and that's what ECHO does very well. And the managed care organizations in Missouri and New Mexico pay for this because they see its value, and we would advocate strongly for that. And last, we would advocate that at least you take a look at opening up the health and behavior codes for psychologists in Mississippi. Other states do this, and they realize great savings in terms of the number of sessions that kids use. It goes down, and kids actually get better quicker. It's an efficient use of dollars. When Medicaid partners wisely, the kids of Mississippi benefit. That's just our underlying line here. We want to improve access to quality care. That child, if you change these things around, that child in Carthage who may or may not have ADHD would be assessed remotely in the school. Treatment could be delivered remotely. That child's teacher may have training to handle behavior problems in the classroom. You cut down on travel to other parts of the state. And all this would be reimbursed at a rate that does not make money for pediatric behavioral health necessarily, but allows it to break even. I've heard it said before by one of my professors in grad school, pediatric behavioral health is sort of like the English department at a state university. You got to have it, but you're not going to make any money off of it. And that's fine. We don't have to, but we also don't have to lose money. And we also don't have to save money for national companies. We want to partner with y'all and with Medicaid on how we take care of the kids of this state, our kids, your kids.
Well, thank you, Mr. Chairman, committee members, for this opportunity to have a discussion about our kids. Let me just say at the outset, thank you for your attentiveness these last 2 days. I know you've heard a lot of feedback from lots of people with ideas, and while I could take this time to join the chorus of pressure points that we experience around credentialing, around continued stay reviews and managed care issues, I really want to spend this time looking through the windshield and not the rearview mirror. And what are the opportunities before us as a state? What are the opportunities before this committee this year that we can do something special for the kids of Mississippi? My name is John Damon. I'm the CEO for Canopy Children's Solutions. We're the state's most comprehensive provider for kids' behavioral health, education, social services, and 18 offices around the state, serving 5,000 to 6,000 kids a year. And I'd love the time to talk about all the behavioral health issues that Dr. Elkin and others have articulated because the needs of our kids are tremendous right now. But I want to take this time to pull the thread on one specific issue, on one issue that is a pressure point that Dr. Elkin brought up, and that is our children with autism. And this committee and the Division of Medicaid have had a great history. We've overcome the initial inertia that is so difficult to get the ball rolling. And we've got this ball rolling. We've got some momentum with innovation that is happening in Mississippi. From the committees that have been created to House Bill 885 that made sure insurance was available for all kids in this state with autism. There was a cap placed on that at age 8, as you might recall. A year and a half or so later, that cap was removed. We have got momentum moving, and right now this year in 2020 is an important time to take the next critical steps. And there's a confluence of some very important issues that have come together that allows that opportunity to take place. Obviously, we have the tech bill opening up, which is tremendous. We have a recent letter to Mr. Snyder and all the other state Medicaid executive directors from CMS encouraging states to move towards value-based care. And now we also have the data to show that I'm going to demonstrate to you today that I have in your packet that value-based care, specifically with kids with autism, is a good return on investment. So this is a great moment, and the time is critical to respond quickly. As you can see in this graph, autism is now the world's fastest growing diagnosis. And in just 37 years, we've moved to 1 in 1,000 kids with autism to now 1 in 54 kids. And I wish I had time to unpack the details of all the stories of kids and families we've seen whose life has been changed. This child on the screen, Catherine Catt, who she came when her mom first called me in tears about us starting autism services. She was in residential treatment in Utah. There was no place, no treatment here in Mississippi. When we opened our program, she got on a plane, flew her back. She went through our program. In about a year and a half, she was back in Madison Public Schools, unassisted in regular classes, graduated a couple years ago, killed the ACT, got a college scholarship, got a driver's license, a boyfriend, and a job, and that's what should happen to all these kids. And that's what's possible for all of these kids. There's also, I'll show you an example. It's not her face, but it's her data of a 2-year-old from Rankin County that came to us and received what Dr. Elkin talked about. The gold standard treatment for autism is applied behavior analysis, ABA. It works, and we know it works. But what we have found in our research, and what the literature also supports that's in the economic impact analysis study that you've been given, is that there is a dose effect. Treatment works, ABA works, but more of it works better. And here's an example of this with this child that's the blue line, who came to us at 2 years of age to get this ABA therapy. And you can see the line slowly improved, but the orange line is the normative sample, or the kids without autism, the neurotypical child. And you can see how their improvement is a steep increase, and hers is not increasing at that level. Well, after a year of doing ABA with this child, the family committed to do not just focus ABA, which is 5 to 10 hours a week, but intensive ABA of 20 to 25 hours a week. And you can see the inflection point on the blue line that this child's trajectory is now towards normal development. In fact, we've got so many examples where those kids not only got to the point of normal development, but exceeded. The ABA works, but more of it, comprehensive ABA, is even more effective. Dosage matters. Now, if you ask that family, how much is that worth to you, that your child is now on a trajectory to go to kindergarten with your neighbors, you can't put a price tag on it. But this body has to put a price tag. I get that. So we engaged one of the country's top economic impact analysis and modeling groups out of New Mexico that has the report in front of you that's reviewed the literature and our literature to be able to say, what does that mean? What is the impact, the financial impact of this type of movement that you've heard about in this body to go from volume-based care to value-based care? And what you see, and I'll just pull out the treatment as usual blue line, but the green line, the focused ABA, this is the cost to the state over the course of this child's life. The black line is the shift to comprehensive ABA through a value-based model. And what you see is by the time this child is an adult at 18, for this one child to shift this model this way to get more dosage of this therapy that works saves the state $652,000 by the time they're 18. And over the course of that child's lifetime, $1.6 million for one child. Mississippi has about 11,000 children who need this care right now. So the savings to the family are incalculable. The savings to the state are real. Now, but there's a big problem, and I know you've heard about this. Mississippi is second to the lowest in our region per capita of providers of ABA therapy. The Lieutenant Governor and others have worked very hard with IHL, Ole Miss and others in the junior colleges to try to get the pipeline moving for more ABA therapists. But there's a reason that there's not many therapists. If they don't have jobs to go to who can pay them, they're not going to go through that in college. It doesn't make sense. And there's no providers hardly for this service because the economic reimbursement model does not work from a business perspective. The only reason I'm standing here telling you about autism today is because for 100 years, over 100 years, our organization has taken on whatever the vexing problem is of kids in Mississippi and has said, we, if not us, then who? And if not now, then when? Let's take on this issue. And several years ago, we took on autism. We've had to personally raise over $2 million just to subsidize this treatment, to demonstrate and have this conversation today to tell you that it works. And our board is committed, our organization is committed, but until we try to change the system to a value-based model that works, even our organization has its limits to be able to do this. So I really wanted to bring to you guys, you've heard a lot of problems the last two days. I want to bring the solution around value-based care with 3 core pillars that it can deliver on: outcomes and quality, access to care, and financial benefits. The outcomes and quality will encourage the shift to more comprehensive dose impact ABA therapy. It also rewards the highest quality providers. Those who do good work will get reimbursed for it. The access to care, it actually strengthens the provider network and expands the effective access to care for our kids and families. And the financial benefits help shift some of that risk to the providers, although Richard's comments are spot on. We're already in a tough spot. We can't take on more risk, but it does put skin in the game to produce the outcomes that we're reimbursed for. And it increases the financial predictability of the budgeting process that you have. Now, this could sound ethereal or theoretical in some way. Is it possible? Let me just tell you, we've done this. In 2006, Mr. Schneider could tell you, when the only treatment option for kids with intense psychiatric residential treatment needs was to go to leave your home, as Dr. Elkin talked about, the trauma of leaving your community, and go to a treatment center. That was the only option. But our state said, we think there's a better way, and we partner with Medicaid and one other organization for our state to write a response to a 1915C waiver from CMS and the federal government to say we could do what has only historically ever been done in a treatment center in their own home, in their own community, across all 82 counties. Mississippi applied, 10 states, of all the states that applied, 10 states were awarded, Florida dropped out, there was 9, and we should all be very proud. Mississippi led the nation in this effort. Georgetown University came down, did video series, took it back to Congress to say this is an ideal model of care. The pilot was tremendously successful. In fact, it was so successful, it became part of our permanent state plan amendment. It is how mental health care is done for this level of kids across all 82 counties now in this state. And here we are in 2020, and these 3 pillars have been proven from quality and access and financial benefits have been demonstrated for these kids across all 82 counties of our state. It's a tremendous program, and it is evidence that we have thought outside the box with innovation, we've pursued the innovation, and we've executed the innovation. And that's the opportunity that we have uniquely right now in this year with autism. So I leave you with these final 2 thoughts as reminders. ABA therapy works, but dose matters. And if we can shift kids whose neuroplasticity of their brain is so sensitive to receive the therapy at an early intervention level and get the care they need, when they need it, for how long they need it, the outcomes for their life are incalculable, but there's very real state savings that come with those costs. And second, we have this unique moment where the opportunity with CMS pressing value-based care, with the tech bill open, and with the data that I've given to you that demonstrates the effectiveness of it, that opportunity coupled with the innovation and the drive from Mr. Snyder and programs and organizations like ours who could engage in an idea, consider something this year, a pilot perhaps, or perhaps an application for a waiver or whatever the division and the committee believes is the right way to go. But we stand poised and ready to partner with you like we have in the past to do something very special for the kids of Mississippi. And I thank you for your time. Thank you.
Thank you. Chairman Hood, you have questions? Any committee members?
Representative Scott.
Yeah, just David. ABA, yes, ma'am.
But it's specifically for the autism spectrum disorder, is what.
That is correct. ABA is targeted.
For children that have deficit, do you not have a recommendation for them since you're across all behavior? That has been one of the greatest problems that we've had in the state, and certainly as we have been on autism. Don't you think that it would be, since this is Medicaid money for poor people, children get the same consideration? Intense showed on the TV show how this particular diagnosis is not in your record.
We welcome anything that would help the kids of Mississippi, and ADHD is a prevalent problem as well. We would back that as well. We would welcome your support in helping us do that. The standard of treatment right now for children with ADHD is twofold. The evidence coming out of multiple labs across the United States, primarily Florida International down in Miami, medication and behavior management. And you're hitting on behavior management when you're talking about ABA therapy. The medication is prescribed medication. Many parents want to have one or the other. It's best when they go together. Unfortunately, some of the kids in Mississippi are merely prescribed medications at a higher rate, or the diagnosis is misdiagnosed. That's not ADHD, it's a reading disorder, or that's depression, or that's anxiety. So we would welcome any efforts to improve the care, especially as that child is in school where the teacher knows what he or she's doing.
African-American children are overrepresented in that that those children with that diagnosis you're requesting this committee to act on this. You tell me that you think it's whatever we think about it. I'm asking you, do you not think that it should go off the way
I do.
that particular diagnosis?
I do apologize for living off ADHD. I do think that it does need to be considered, yes.
So would you modify your, this, request that you have?
Absolutely.
Okay, and my last question to you is that the extent of the, I noticed that it also is, more directed towards autism. But that same, community healthcare, model could also be replicated deficit disorder as well. Yes, to also include not only autism in that ECHO project, but to include the attention.
Absolutely. In fact, the ECHO project isn't limited to just autism. It covers the entire spectrum of all children, early development through child, any kind of behavioral, emotional, developmental disorder. So the ECHO project isn't limited just to autism. So it covers everything already.
Also include what you, cost of general fund that you take these recommendations. I'm interested in. I do think that,
we stand ready to help. Thank you for the reminders.
Thank you, doctors, for your presentation. Enjoyed it. Last but not least, we have the Department of Mental Health. You may begin, ma'am.
Thank you. Good morning. Chairman Blackwell and Chairman Hood, we appreciate the opportunity to present to the committee and appreciate your time as well. This morning I have with me Ms. Wendy Bailey, who is the Deputy Executive Director for Administrative Services, and Mr. Kelly Breland, who is the Bureau Director for Administration. He's basically our Chief Financial Officer for the agency, and he'll be presenting with me this morning. We've provided you a handout, and I really want to start just with a little bit of the state's mental health, an overview of the state's mental health services that we have. And the reason I want to do that is you heard several providers today. You've heard from community mental health centers. You've also heard from some private providers, and I think it's important for you to understand what makes up the state mental health system. The state mental health system is currently made up of three major components. The first component is the state-operated institutional and community service programs. The first 6 programs you see listed on your slide are regional centers. And our regional centers serve individuals with intellectual and developmental disabilities. The institutional care that's provided at our regional centers are provided to individuals needing the highest level of care possible, and that is provided on the agency's main campus. Also, our regional centers provide community services that are provided through 10-bed ICF IDD homes, as well as services provided through the Medicaid IDD home and community-based waiver. The next 6 programs that you see listed under number 1 on your slide are our behavioral health agencies. These are our state hospitals. We have 4 state hospitals across the state: East Mississippi State Hospital, North Mississippi State Hospital, South Mississippi State Hospital, and Mississippi State Hospital. Our state hospitals comprise the largest component of our psychiatric treatment. We all know that at any time a person of any age could need treatment for a serious mental health condition. These are inpatient psychiatric hospitals, and they specialize in providing the most intensive treatment services available to individuals. Also, as a component of our state hospitals at East Mississippi State Hospital and Mississippi State Hospital are nursing homes. So that's an important component. They are state nursing homes. They are licensed by the health department, and they operate under their licensure regulations, and they are reimbursed under the Medicaid program on a full allowable cost reimbursement. The second component of the mental health system are the regional community mental health centers. There's 14 of those, and I think you heard from the community mental health center associations today to kind of show you where they fit in our delivery system. And then in addition to that, we have our other not-for-profit service agencies and organizations. Today you heard from 2 of our not-for-profit service organizations, but it's important to realize that we have 147 certified providers that we certify through the Department of Mental Health. And they're going to be providing services such as alcohol and drug services, mental health services, maybe for all populations, adult and children. Some of these providers just provide services for children, as well as we have providers for IDD services who are primarily providing the home and community-based waiver services through our IDD, home and community-based waiver. And so it's a large system. I do want to acknowledge the partnership that we have with the Division of Medicaid. We have a very good working relationship. Mr. Snyder and his team are very committed to the issues that are important to our agency related to the expansion of community-based services in the state. So with that, I'm going to ask Mr. Breland to make a few comments, and I'll be available for questions.
Good morning, Mr. Chairman, committee members. Briefly, I'd like to go through the services that we provide and their relation to Medicaid under the reimbursement methods that we have available to us. The first one is on, as Ms. Mikula mentioned, the IDD regional programs. And these are at, generally speaking, at full allowable, reasonable cost reimbursement is how they're reimbursed. So for most Medicaid services,
a provider provides a service, bills Medicaid. If that payment is made to that provider, the Division of Medicaid sends to the federal government the state portion of that service. That's generally the typical way that it works. For the Department of Mental Health, the legislature appropriates that portion that Medicaid sends to the federal government to the Department of Mental Health for almost all the services, if not every one of them that we provide that are under that system. So whenever there's $100 that is spent for a reasonable, full allowable cost under the Medicaid program at one of these IDD agencies or the nursing homes that I'm going to mention in a minute, that $100, whatever the match rate is, currently about 16.8% under the pandemic conditions, then $16.80 of that would be billed to the Department of Mental Health, and we would pay that to the Division of Medicaid. They would then transfer that to the federal government. So it's a little bit different in the mechanics of how it works. We pay our own state share on those services. So these are licensed under intermediate care facilities for intellectual and developmental disabilities for those individuals. There's about 806 of those on the main campuses of these IDD programs. There's about 528 of those that are in 10-bed units, which are still licensed as an ICF IID, meaning that they are still under full reasonable cost. The pie chart depicts here a general overview of their expenditures for the most recent period ended fiscal year 2020, and shows about 83% of that spending is special funds. That's where the agencies are using cash and reimbursement revenue that's coming in for their operations. And then, as I mentioned, the legislature appropriates general funds to those agencies, which they in turn send to the Division of Medicaid based on billings for those services, whatever those billing services are that are allowable. I mentioned that there's 16.82%. That number is about, when you work the math out, you're spending that 83% there. And then on top of that, again, spending the mechanical piece of paying the state share, which in a sense gives a bloated view of what really is happening. So that 83%, that number, 220 million, that really is more indicative of the operations of those agencies instead of adding in those general funds and healthcare funds, which primarily would be used for anything that's either not allowable or for that state share component. Under normal circumstances during this time of year, the match rate at September 30th would have been 23.02%, and the state share currently is 16.82. I remember some discussion yesterday about when that would end. My understanding is that would be when the Treasurer, United States Treasurer, declares that during that quarter. At the end of that quarter, it would subside at that point, is the way I understand that would happen. So as far as I know, that hasn't happened, which means it should run through December 31st of this year at least. So the next slide we've got is a more complicated group of services, which are the state hospitals. And it's more complicated because there's the main service that they provide. So inpatient, acute, psychiatric hospitalization. That service generally has different components made up of its reimbursement, including Medicare, Social Security benefits of that person if it meets some standards, and also private pay and any donations or anything else that comes to the agencies. But it's primarily general funds appropriated from this legislature. That's where their funding source comes from. Then we've got the nursing homes, as mentioned earlier. Basically, reimbursement-wise, they are akin to the ICF IIDs. Full allowable reasonable cost reimbursement under that program, and they are licensed as nursing home facilities. Then we have Oak Circle Center, which is a children and adolescent acute psychiatric hospital on the campus of Mississippi State Hospital. Again, still reimbursed under that method, but generally not as many kids may qualify for Medicaid. They may be excluded from that, or they could be participating in an MCO, which means that those services would be covered in a little bit different mechanism than the full allowable cost under Medicaid. So a little bit more of a mix there in reimbursement that's different. And then we've got specialized treatment facility, which is under Mississippi State Hospital. That is a PRTF, psychiatric residential treatment facility. which was shifted, I believe, a couple of years ago to the MCO as a provider under MCO instead of being under the Medicaid program. And then there are a few community services that are offered as transitional services within those state hospitals, mainly at East Mississippi State Hospital. And I've also got the same style graph there just to give you a general idea of 57% of those behavioral health expenditures are general funds, and then about another 3% or so are healthcare funds, and then the special funds are those Medicare, some Medicaid for the nursing homes, and private pay, and various other Social Security and other types of reimbursements that those hospitals get. And then finally, as far as the main points of what we're providing as the department, we don't provide as many of these services, but for the IDDD, Medicaid Home and Community-Based Waiver, which has its own slide, this waiver is open to providers that meet qualifications, and when they bill Medicaid, very similarly, the state, through the Department of Mental Health, pays the state share of match for all of those providers. So Medicaid sends a bill of here's the revenue or the billings that have been paid out of Medicaid. They multiply it times the state share at the time that's applicable, and we pay that state share to them. This has been a struggle to keep up with the demand funding-wise, and it continues to be with a great number on the planning list for these services, which are, is about 2,500 people. So 2,500 people waiting for services in the IDDD waiver so that they can be served there in a home and community-based setting. And so for the latest year is about 137 million. If you take that turquoise bar there on the furthest year on the right, fiscal year 2020, that 137 million is the revenue piece or the billings. That black portion on the top is, again, that a little bit of a bloated view of it, but that's the state portion that's paid back to Medicaid based on those services. We continue to and have been trying to get more funding for that and work through the appropriation committees to do that based on the need that's there in the community. And so not to go too much into it because you've already heard several things about this, but the Department of Mental Health is definitely supportive of some reimbursement mechanism. The only one that seems to be floating some of our providers now, from what they tell us, is the current not paying less than a certain rate, which is usually benchmarked on the Medicaid rate. Those types of things. Claims are always an issue no matter what insurance you're going through, but it seems like they're having a lot of difficulty with claims being paid. Some of that credentialing, you've heard all of that. We hear those complaints, so I won't rehash any of those because we're not as aware of those because we're under that full cost reimbursement, which is one of the main points of saying that is a good thing for the Medicaid program and for the state and the Department of Mental Health. Without that, people are going to come to the state hospitals, be committed to the state hospitals. When they get there, if there's not a way of paying for that in the community before they would get to that level of care to keep them in the community, then the state's going to pay for that one way or another. That's just how it's going to work. So if there's a way, as Ms. Cole mentioned earlier, to erode that the MCO is getting paid over here and the Department of Mental Health is supplementing that because of the coordination of that care is not happening like we would all agree ideally we would want it to happen, I think, then that's a problem for the state. And that's where we've got some efficiency that we could maximize. And that's not just an MCO issue, that's the stakeholders. And includes the Department of Mental Health and working towards that goal. So, questions, Mr. Chairman?
Chairman Hood, any members of the committee? Representative Curry.
Thank you, Mr. Chairman. And right now, you heard me say that my community mental health is owed $850,000. What is the state hospital owed right now from MCOs?
I don't know that they are owed anything from MCOs. There's a very little, and I forgot to mention this, thank you, Ms. Curry, generally those state psychiatric hospitals are precluded or banned from being able to bill under the Medicaid program. So there's what's called the Institutes for Mental Disease, which is a federal policy that precludes that. You cannot bill under those services. Typically, there is one exception for MCOs, but it's a pretty new service, and we're still yet to get traction on billing for that service. But that's one little piece of it that is allowable in there, but it's not a huge portion of our billing at this point. And we don't know that it ever will be, but it will be some part, and that's just been within the past year or so.
So you're kind of excluded from that program. Lucky you.
We are insulated to some extent. Specialized treatment facility
Right.
is kind of in there. I would have to check on them to see how much they're owed there, if any. And then Oak Circle Center, the Children's Hospital at Mississippi State Hospital, that service, if the person has an MCO as their insurance when they come in, then I think they bill under it. So they could be one too, but generally we are pretty insulated from that.
And I know the concerns in the past for you guys are making sure that we don't allow the MCOs to get involved in your waiver program at all. That's a really big deal still, just that we make sure that that doesn't happen. So thank y'all. I know you're doing a lot of good work, and that this is struggling time, and I appreciate you coming today.
Representative Scott.
Excuse me, Representative Scott, could you use a microphone? We've had some individuals online that can't hear you.
You need to step.
Excuse me. Oh, can you tell the committee, the gentleman, I don't know if you were here or not, he represented that the state plan shows where there is a need for the facilities to be increased. In my area, does the state plan show that?
He was specifically speaking about North Mississippi, and I will say that is correct. I'm not aware that there is an adolescent psychiatric treatment facility in the north part of the state. The two facilities that we operate at Mississippi State Hospital, Oak Circle Center, and at STF, Specialized Treatment Facility on the Gulf Coast, we provide services statewide. But he probably is correct, and I don't know specifically. I think he was mentioning just in the north part of the state. So there is the possibility, it exists today, if you need services and you're going to receive services from the state of Mississippi through one of our agency programs, if you are in Lafayette County, the access to services for a state hospital-operated program is Oak Circle Center for acute and specialized treatment facility on the coast for PRTF.
And Oak Circle is not at full capacity?
No, it is not.
Okay, then my last question to you, Boswell. We also got some testimony that the chemical dependency beds are 410 in the state, and that 2/3 of those are private and only 1/3 of those are state-owned. And of course, the state-owned ones are the ones where we can kind of pick up the phone and say, you know, we need some help. And certainly we know that the chemical dependency beds, I think everybody on this committee would say that that's one of the many calls other than crisis intervention, and many times that's about drugs. It's something that's, that is an acute situation for us here in the state. Has there been any consideration about making some changes at Boswell to try to address, since they've had some reduction as well, as looking at, because it had a dual purpose a long time ago, as we all know, maybe looking at having some additional chemical dependency beds there at Boswell, since we have the space, we got the, you know, we got all of the infrastructure there.
There is the possibility to repurpose at many of our locations, as you're indicating, because we are downsizing and right-sizing many of those programs. This would be an issue of just the funding that would be needed. I don't believe it could be absorbed within Boswell's current budget. And what we've done as an agency, I think it was mentioned earlier, we have been every opportunity moving resources to expand community services. So several years ago, we moved $10 million out of our budget, $8 million for expansion of behavioral health, and actually $2 million for expansion of the home and community-based waiver. And then this last year in our appropriation, the legislature did direct us to take $4 million out of our existing operation to fund expansion of community-based services, which I agree, that's an important thing. We've got to continue. The services need to be available in the community. But when we do that, then we have to decide how we're going to fund those additional alcohol and drug beds.
Okay, so if the legislature were to try and work with you in this capacity, there is a way that, and you're talking about repurposing all over the state, we would have the ability to have people close to home as they're going through all of that's involved if we were to make the investment. Well, thank you so much. I appreciate it. I certainly hope, Mr. Chairman, that maybe this is something that we could look into doing, because as we all know, with this opioid and then all people being, you know, COVID and all, you know, it's just the drug situation has gotten to be even worse, is what the sheriff was telling me. So I hope that this is something that we can look at, because the state already has the infrastructure in place.
Thank you, lady. Thank you for your input. We're going to have two more presenters, and we're running over time, and it's going to recognize Senator Blunt for a question.
Thank you, Mr. Chairman. First, I'd like to ask you for information on uncompensated care that you provide. You can do that either briefly now or offline, which I assume state dollars pay for 100% of those costs. And so I guess share with the committee briefly what that looks like, and then offline you can get with me to identify whether there are people who are currently not eligible for Medicaid where the state is paying 100% of the cost of their care that might be eligible we were to expand.
So I think I don't have as much information, Senator Blunt, on uncompensated care, other than whatever is uncompensated generally gets reimbursed to those agencies either through this legislature in a direct appropriation of general funds, or works through the DISH model and the UPL models as under the full reasonable cost model.
So we do have information on that, and we can get that for you, which they do have cost reports on. I just don't have specifics on that because typically that's filled in. The gaps in funding for these hospitals typically are filled in with state general fund or healthcare fund appropriations.
That'd be fine, but that's 100% state funding, 100% general fund.
Typically, and I guess to address your second question, as I mentioned with the IMD exclusion, it won't matter if those people come into the state hospitals with Medicaid. It shuts off immediately when they come in the door by the federal policy called IMD exclusion. So those costs are seen, I think, on just about every level, federal, state, and local, as being pretty well the state's problem to fund and deal with. So, and that the federal government's not going to generally. But there are personal benefits like Medicare, where that if they're in an inpatient acute setting and they have Medicare and they haven't exhausted their lifetime benefit, those days are billed by those hospitals when they're appropriate. There could be someone who gets committed, they're not appropriate for inpatient hospitalization at a state hospital, but that doesn't mean they're not going there because the judge said they were going to. So that wouldn't meet criteria probably for Medicare inpatient Part A type hospitalization. So there are a mixture, Social Security and some other ones, but the heavy lifter here, so to speak, is the funding of general funds from the legislature to those agencies, especially for the acute and continued treatment psych services.
And then the lawsuit was referenced in the remarks by the community mental health centers. Can you give us an update on where that stands?
Yes, sir. On September 6th of 2019, you'll recall that Judge Carlton Reeves found the state is violating Title II of the Americans with Disability Act, but he did not order a specific remedy. He indicated that he thought this was well suited for a special master to help the parties craft a plan. The special master was appointed on February the 25th. Since then, the Department of Mental Health, with Department of Justice, the special master, and our legal representation, as well as Division of Medicaid, have been involved in ongoing negotiations to craft a remedy. There have been 2 status calls with Judge Reeves. The first one was on April the 27th, and the last one was on October 2nd. So we are moving forward, trying to come up with an agreeable proposal, a remedy to the findings in the memorandum and order of Judge Reeves.
So we just don't know at this stage whether that agreement between the parties will require the legislature to do something in the next session or not. Y'all just trying to hash it out. Is that right?
We're currently in the legislature, as I mentioned, the additional $4 million that the legislature redirected for us to spend on community services. We have offered additional state source grants this year to community mental health centers, primarily to expand the community services. So we're currently just trying to address all the at-issue services and expansion needs related to an agreement.
Thank you. We're going to conclude with Representative Boyd.
Thank you, Mr. Chairman. I think it's a pretty short question. On this graph, I understood that the black line was to show the money that you reimbursed or gave to the MCOs. Is that correct?
No, sir. That black line is the state share that the Department of Mental Health is charged with transferring to the Division of Medicaid for that portion. So most services, the Division of Medicaid transfers that to the federal government. You all appropriate that money for them to do that. Okay. In our case, and with all the services just about that we have, when it's Medicaid, we have the money in our appropriation. You appropriate that money to us for paying that state share to Medicaid, and then they transfer it. So it's just a little bit different mechanism. So it just gives you, for instance, the $137 million there in the turquoise on the right side. That's the actual billings that have come from Medicaid. So those are providers that are providing that service, and they're billing different types of services. That's just the total for that year, $137 million. Division of Medicaid multiplies that monthly, of course, but on the whole, there was $27.7 million that they billed us and said, Department of Mental Health, we need this general fund dollar, these general fund dollars transferred to us, and that's what we do. That's that amount.
And that money's matched by the federal?
That is the state share match, yes, sir.
Okay, thank you.
Thank you. We appreciate your presentation. In fact, I just want to comment, we certainly appreciate all the presenters over the last 2 days. Also want to recognize the Capitol staff who helped arrange and get everybody here. Chairman Hood and his committee for attending, and obviously the Senate Medicaid folks. We'll be back here on the 26th and the 27th with 2 more days of full hearings. So Chairman Hood, you have anything?
I just want to thank everybody for attending, everybody that gave a presentation, and I want to thank everybody at the Department of Health for what you do. I know anytime I've ever contacted y'all, you've been very helpful, and you definitely supply a need to this state, and we appreciate you coming here for your testimony. And I'd like to thank all the House and Senate members as well, and we'll see y'all on the 26th. Thanks.